We are going to learn about all things medication administration. So, as we start to get into reading drug labels, it's important that we know all of the information that is drug related on these drug labels. A drug may have multiple names that we'll see on the label or in a drug reference, the first being a chemical name. So, when we're talking about a chemical name, this is the exact description of the drug's chemical composition and its molecular structure. So, typically, this name is very complicated, very long, cumbersome for the general population to use, so we don't see it used in layman's language very often. The generic name, or a non-proprietary name, you may hear it called, this is assigned by the United States Adopted Names Council when the developing manufacturer is ready to market that drug. This is usually similar to the chemical name, but it's in a simpler form, more easy to pronounce, even though these generic names are typically hard to pronounce. They're the odd kind of sounding names that you hear, like acetaminophen. Or in the case of this drug label, erythromycin is going to be your generic name. You may also hear a generic name and official name used interchangeably. An official name is also just the generic name that is listed in publications such as the Pharmacopoeia or the National Formulary, you may see as well. So those are kind of interchangeable. And then we can see the brand name, or you may call it a trade name or a proprietary name. This is what the drug is sold as in stores. The brand name is easily recognized because it begins with a capital letter and sometimes has a registration or a trademark symbol in the upper right hand of the name. Different manufacturers of the same medication can give it different brand names, okay? So here for this particular drug label that we're looking at, your brand name is going to be the Erie tab right here. You can see it's capitalized, has that registration symbol there off to the right. Other manufacturers may purchase this erythromycin and use it, brand it under a different name other than Erie tab. That's what it's kind of talking about with that. So those are the different kinds of names. Keep in mind, there's always prescription drugs and there's non-prescription drugs. So when we're talking about in this PowerPoint about a prescription drug, these require a written prescription from a healthcare provider. So any type of provider, physician, advanced practice nurse, someone who is licensed by the state to prescribe or dispense drugs. And then your non-prescription drugs are the over-the-counter or OTC, you may see it abbreviated. Those drugs may be purchased without a prescription and are assumed to be safe for the general population if consumers follow the manufacturer's directions. So this is your over-the-counter Tylenol, your ibuprofen, your Colace, those kinds of things. Now we're going to dig into promoting medication quality and safety. As nurses, it's going to be impossible to know absolutely everything about a drug. We are asked to give drugs that we've never heard of often. So it is our job to be able to know how to look that medication up so that we can give it and administer it safely. Because even though it's not necessarily possible for us to know absolutely everything about a drug, it is our job to know enough about that drug to give it safely every single time we give it. So some reliable sources for drug information, state and federal regulations and standards controlling drug administration, a variety of systems for storing and distributing medications in healthcare agencies. All of these things all work together to protect consumers. The following things are going to be used when researching medications or a drug of some kind. So your pharmacopoeia or your drug formularies, nursing drug handbooks, which you can see a picture of off to the right-hand side, a physician's desk reference, pharmacology textbooks, electronic or internet-based formularies. So you may see Epocrates is a good app that is used a lot of times to identify drugs, common side effects, things like that. Drugs.com can be very helpful. A clinical pharmacist. So that is a great resource that we have working in a hospital environment, or even if you work in a long-term care and you don't have a pharmacist on staff, oftentimes there is a pharmacist that's going to supply those drugs in some way, shape, or form. If it's an outside company, you can always call the pharmacy and ask them questions about the drugs or the dosing, just to be clear and be safe. Medication package inserts. So these package inserts come with every single medication. It's very similar to like a label that you would see on a Tylenol bottle. Those are great for showing you recommended dosage ranges. So you can say, is this dose safe for my patient? How often is this supposed to be given? Can it be given IV? Is it given PO? Those kinds of things. And then institutional medication policies and procedures. This guides a lot of the medications that we give on a day-to-day, shift-to-shift basis at work. So policy is super, super important. Federal, state, and local laws control drug administration. Standards of nursing practice, state nurse practice acts, and organizational policies and procedures are going to define your role and your responsibilities in administering medication. So all that is going to vary based on where you live, what is your policy at your hospital, things like that. So you have to be familiar with all of these things to know what you can and cannot do, as well as know any limitations like to yourself based on your own experience, your own skills, your own knowledge, and gaps within that learning spectrum there. So the U.S. drug legislation, they're going to set those official drug standards. They're going to define prescription drugs. They regulate those controlled substances. They improve safety when it comes to administering medications and receiving medications. And then it's also going to require a proof of efficacy. So is this an effective medication? Those kinds of things. Nurse practice acts and institutional policy. These things are going to identify nursing responsibilities for administration of medication and also the required client monitoring. So in most states, a nurse cannot prescribe or administer medications without an authorized provider, like a physician, advanced practice nurse, without a prescription from an authorized provider. State boards of nursing also regulate the types and routes of medication that can and cannot be administered by various levels of nurses. For instance, in some states, LPNs cannot administer IV medications. In some places, they can. Violating your scope of practice can result in disciplinary action no matter where you live or work. The big thing is being familiar with the one of your state. So we live in Indiana. Indiana's Nurse Practice Act is very, very, very vague on purpose. For the most part, it is a kind of a train and do type of state. So institutional policy is really where we kind of get our do's and don'ts, because a lot of long-term care places, LPNs are going to be able to start IVs and maintain IVs. However, when they go to the hospital, their policies may be different. So it's just important to follow that guidance at your healthcare facility and know kind of the do's and don'ts inside that Nurse Practice Act. So the Food and Drug Administration of the U.S. Department of Health and Human Services is going to regulate the manufacture and the sale of all medications and monitors their safety and effectiveness. It's also going to regulate through controlled clinical trials, the testing of medication that's to be marketed and sold in the United States. However, the process of that may be different than what you thought that it was. I know I was enlightened to learn this a few years ago. So first step, so the drug company that is wanting to get their drug approved is going to first test their own drug and verify that it works correctly and that the health benefits outweigh the risks. So the drug company is doing the testing and determining that the health benefits outweigh the risk. Okay. Step 2, evidence from those tests are then sent to the FDA's Center for Drug Evaluation and Research, or CDER. Okay. Generally, the agency expects that the drug maker will submit results from 2 well-designed clinical trials to be sure that the findings from the first trial are not the result of some kind of chance or bias. So after they get those results, they're going to send them in to the FDA, the CDER portion of the FDA. CDER's teams, which is comprised of physicians, scientists, pharmacologists, chemists, a bunch of smart people, they're going to review all that data that was gotten from the drug maker. Okay. Step 4, if that data is found to show health benefits do outweigh the risks, the drug is then approved for sale. So from this process, we've learned that the CDER or the FDA does not test the drug themselves. These drugs are always tested by the party looking to approve the drug. Then we have complementary and alternative medicine. So this is going to be stuff that's not technically FDA approved that people use for their health benefits that are well recorded. So any kind of treatment or service outside the traditional healthcare system are going to be known as that complementary and alternative medicine. So that this includes systems such as homeopathy, naturopathy, chiropractic, and traditional Chinese medicine, as well as specific treatments such as herbal medications, dietary changes, massage therapy, yoga, aromatherapy, prayer, hypnotism, things like that. It is important to know when we are taking care of patients who are on some type of complementary and alternative medicine that certain dietary supplements, certain herbal remedies, tinctures, vitamins, etc., some of those things can interact with other drugs that we prescribe. So it is super important for us to know what our patient is taking, because if we give them something in the hospital that can interact with those things that they've already been taking, that can cause a big problem. So there is a growing interest in complementary and alternative medicine for various reasons, including the cost of traditional healthcare and increasing cultural diversity in our population. So let's talk about controlled substances. So controlled substances are drugs considered to have either limited medical use or the high potential for abuse and addiction. So under the Controlled Substance Act of the Comprehensive Drug Abuse Prevention and Control Act of 1970, it is illegal to possess a controlled substance without a valid prescription. Controlled substances are classified by schedule. Schedule 1 being the least medical use and the most potential for addiction, down to Schedule 5, which is the least potential for addiction, to the most medical use, right? So when we talk about a Schedule 1 drug, this is going to talk about drugs that have a high potential for abuse and no acceptable medical use. So we're talking about heroin, LSD, MDMA, ecstasy. Marijuana is actually a Schedule 1 drug in Indiana still. It has been reclassified in Colorado to a Schedule 2. However, here it's still Schedule 1. And then also things like GHB, all that kind of stuff. Okay, Schedule 1s. When we're talking about Schedule 2s, this is going to be drugs that do have an acceptable medical use, but still have a high potential for abuse. So Adderall, cocaine, methamphetamines, Demerol, morphine, opium, OxyContin, Percocet, things like that. And then we're going to talk about Schedule 3s, which identifies a medically acceptable drug. However, we know that they may cause a low physical but a high psychological dependence. Drugs in this category examples are going to be things like ketamine, also medications that have codeine that is less than 90 milligrams, so a Tylenol that has codeine in it, and then also hydrocodone in less than 15 milligrams, so a Vicodin would be a Schedule 3 as well. Schedule 4 is going to identify medically acceptable drugs that may cause mild physical or psychological dependence. Examples here, we're talking about Ambien, Ativan, Valium, Xanax, things like that. And then a Schedule 5, which is going to identify medically acceptable drugs with limited potential to cause dependence. So even Robitussin cough syrup, atropine, sulfate, things like that, CBD oil. And then Schedule 6 is also listed on your graphic here, and these are just your over-the-counter availability. These are legal without a prescription, but also known to cause dependence as well in some cases. As you can see, alcohol, aspirin, caffeine, nitrous, NyQuil, and tobacco. There are a few nursing considerations we want to know as nurses when we are handling controlled substances on the unit. So first of all, they must be stored, handled, disposed, and administered by regulations established by the DEA. Okay? Only prescribers with a national provider identification number can prescribe these medications. When they are stored, they must be under a double lock. So there must be either two locks or double identification of some kind to be able to get out these medications. Facilities must keep a record of every single dose of a narcotic or controlled substance that's administered. A count must be kept and performed at specific times for all of these medications. So a lot of times it'll be if you're on like a long-term care unit, you'll have to do a narcotics count before your shift starts and after your shift ends with the other nurse to verify that all of the medications that are missing were written down, that they were given to a patient. And then in automatic dispensing systems, like we'll talk about in a minute, in those, like a Pyxis or an Omnicell, those ones keep count as well. But every time you go to take out a controlled substance, it will say, please perform a count. What the machine is doing at that time is saying, okay, this person that's trying to get out this med says that there's 20 pills in here, but the last time someone took one out, there was said that there was 25. So now there's 4 in here that are unaccounted for. So it kind of keeps a record like that, which will show a discrepancy, which management will have to follow up on to figure out what happened to those medications. And that's a huge deal if you get caught under any suspicion of those medications going missing. So being very, very diligent in where those narcotics are going and making sure that you are keeping a record is super important. And then lastly, any unused medication must be wasted with a witness. So what that means is if you're pulling out, let's say, God forbid, 20 milligrams of oxycodone, 1 tablet, right? And then your patient has an order for 10 milligrams. We're only going to give half of a tablet. So you have to pull out that whole tablet, break it in half, give your patient half that tablet. Now you're left with half a tablet that your patient doesn't need to take. You can't just throw that in the trash. You can't stick it in your pocket. You're going to have to dispose of it with a witness. So that means you go grab another nurse on the unit, you go back to your Pyxis or wherever, and you have to sometimes go right into that Pyxis. Actually, your witness will have to sign in and verify that they saw you take that medication and dispose of it appropriately. So some places will have a liquid solution that you can throw it in there called a drug buster, things like that. So whatever the policy is for disposing of that, you have to make sure that you have someone who's witnessed it, because otherwise, who's to say that it didn't just end up in your pocket? Now let's talk a little bit about the systems that we have that help us store medications. So we're going to talk a little bit of terminology as far as medication supply and medication systems go. You may see some combination of all of these depending on where you work. So first we'll talk about stock supply. So when we're talking about stock supply, this is like essentially a bulk quantity of medication. So stock supplies require you to measure the dose each time a patient needs it. So we're talking like, let's say a big container of like an acetaminophen elixir, a liquid cough syrup, something like that in a multi-dose bottle that you're giving for the patient. So you have to measure that dose every single time your patient needs it. So the potential for a measurement error is present each time a dose is prepared. That is a con of a stock supply, right? However, a bulk or stock supply of medication is very cost effective for the facility. But those multi-dose bottles, depending on where you work and how it's set up, can be used just for one patient, or there may be like a stock supply that's still used for all patients. You may have one Robitussin bottle for all the patients whenever a patient needs it. Next is a unit dose. So a unit dose is like the prescribed amount of the drug that the patient receives at a single time. So each unit dose, so let's say 1 tablet, is individually packaged and labeled with the drug name, the dose, the expiration date, sometimes the patient's name even. And the pharmacist checks each unit dose before sending the drug to the nursing unit. Once it gets to the nursing unit, you're going to be checking the med, so right before you give it to the patient. So that recheck is done by you right before administration. That unit dose system it not only saves nursing time, but it also is the safest method because of that double check system. So typically you'll see these unit dose medications used in nursing homes inside a locked mobile cart, like you can see in the picture down here. Typically, those drawers will contain separate compartments, maybe for each patient, and then maybe another compartment for extra supplies, such as medication cups, syringes, alcohol swabs, things like that. And then lastly, self-administration. So at times while in the hospital, patients may self-administer medications. However, it does have to be approved through pharmacy. For example, sublingual nitroglycerin, like we use for chest pain, is self-administered in the outpatient setting, and some patients can continue to self-administer that drug while in the hospital, depending on what's going on with the patient. Right? The drugs that are prescribed for self-administration are supplied in individual containers and stored at the bedside. You can see it just looks like a pill bottle in the picture here. You also may see in nursing homes as well. They may come right from home and they're not using the pharmacy that the nursing home uses, so they bring in all their own pill bottles. It is in there, but typically if they're doing some kind of self-administration, it does need to go through the pharmacy. So that the pharmacy can approve any other medications that may have been ordered for that patient, that there's no interactions or unintended side effects that may happen from taking those in combination with what they are prescribed at the hospital. An automated dispensing system is a computerized system that is going to hold medication so that we can pull it out when we need it. This locked cart contains all the medications that are frequently used on a particular nursing unit. So the medications differ depending on where this machine's located. You'll definitely need different medications more often in the ER than you would if it was an OB unit, right? So it holds those frequently used medications for that particular unit. And it also has a computerized database that contains, records, and counts all of those medications, as well as the medication prescriptions for each patient on the unit. The medications are usually packaged in unit doses, like we talked about. It has those little individually packaged tablets or capsules in there that has the name, the dose, all on that little like plastic roll that it's in. Most of them in here are unit doses. However, it can carry bulk medications as well, or stock supply like we just talked about, especially in things like insulin. I know the long-acting insulin, at least at Ball, and the one that I use, is a multi-dose vial for that long-acting insulin, which you can pull out the insulin that you need for each patient from that same vial. These automated dispensers are really nice because it does decrease the frequency of medication errors, because it allows us to do our first check here. The pharmacy stocks these drawers. We're able to do all of our checks here and pull out our medications. One of the big problems, though, as I've seen studying medication errors over the past little bit, is that a lot of medication errors come from pharmacy stocking the wrong med in these dispensing units. So doing your 3 checks, especially the 2 checks that are done right here at the dispensing unit, are super, super, super important. However, this method, automated dispensing systems, are great because it also allows for immediate administration of like newly prescribed medications, such as like anything that they need to take right now, some kind of PRN medication, controlled substances, anything that you need in an emergency. It's all here very quickly able to be grabbed, because we don't have to file a prescription and wait for it to be filled. It's just right here at the touch of a button. All right, moving on to some pharmacological considerations. Let's really get into the nitty-gritty of how all of this drug interactions work with and in the body. When we're talking about drugs, 2 really, really important principles that we need to know how to differentiate between include pharmacokinetics and pharmacodynamics. So when we're talking about pharmacokinetics, what we're talking about is how does the body process a drug once it receives it, okay? It's focused mostly on that drug and what happens to the drug in the body by the body, okay? So we're referring to 4 processes when we're talking about pharmacokinetics. The first process being absorption. The second, distribution. The third, drug metabolism. And the fourth is drug excretion. Okay, these 4 processes together determine the intensity and the duration of the drug's actions. Okay, each drug has very unique pharmacokinetic characteristics. And then pharmacodynamics. So this is going to look at the complex interactions between the drug, the body, and the disease process. So for example, if you have a patient who has an infection, pharmacodynamics is going to look at the interactions of that antibiotic ordered. What is the mechanism of action on those pathogens causing that infection? What is this drug doing to those pathogens? Okay, it's also going to look at maybe the patient's full body assessment, the lab results, and then also just more in detail on that pathogen of what is causing that infection, how it all works together. How does that drug work on this particular whole unit? Okay. So let's look a little deeper at pharmacokinetics. So first we'll talk about absorption. So absorption is going to refer to the movement of the drug from the site of administration into the bloodstream. Okay, so site of administration meaning intramuscularly or intravenously or orally, whatever that is. Okay, the rate of absorption determines when a drug becomes available to exert its action. So the absorption also influences metabolism and excretion in that way. Absorption depends on the route of administration. It also depends on drug solubility, the effects of pH, blood flow to the area. We know that if we're giving a medication intravenously, it's going to absorb faster than if we were going to give it orally, right? So that's going to play a role. Blood flow to the area is super important as well. That's why a lot of times heat will increase blood flow to the area, will also increase absorption of a lot of topical medications. Okay, so blood flow to the area is super important as well. We're also going to talk about distribution. So distribution is the transportation of a drug in the body fluids, usually the bloodstream, to the various tissues and organs of the body. Okay, so because blood goes to all parts of the body, theoretically, a drug can produce effects anywhere, whether they be intended or unintended. The rate of distribution depends on the adequacy of local blood flow in that target area, which is wherever the target area is that you want that drug effect to occur. Depending on the blood flow in that area, is going to increase the rate of distribution or decrease it depending on the blood flow. Okay. It is also influenced by the permeability of capillaries to the drug's molecules, as well as the protein binding capacity of that drug. So all of those things go into drug distribution. Drug metabolism. This is the chemical inactivation of a drug through its conversion into a more water-soluble compound or into metabolites that can be excreted from the body. Okay, so once a medication reaches its site of action, it is then metabolized, so changed into that inactive form, in preparation for it to be excreted eventually. Okay, metabolization or metabolism takes place mainly in the liver. Okay, drug metabolism takes place mainly in the liver. This can be noted as the first pass effect, if you've ever heard that. This first pass effect refers to when a drug is taken in and then it is metabolized in the liver before it even reaches really its target destination, decreasing its effectiveness, right? So a lot of times that's why you'll see that oral medication dosages are a lot higher than medication dosages that you would give intravenously, because if you're giving something intravenously, it's not going to go through that first pass effect the way that it does through an oral administration route. As I said, metabolism takes place mainly in the liver. However, medications can still be detoxified also in the kidneys, the blood plasma, intestinal mucosa, and in the lungs as well. And then lastly, we have excretion. So for excretion to occur, drug molecules must be removed from their sites of action and eliminated from the body. Drugs may be metabolized completely, partially, or not at all by the time that they are excreted. The following are common organs of excretion, mostly the kidneys, okay? The kidneys are going to do most of the excretion, okay? That's important to know. Also helping the kidneys in some drugs is going to be the liver, the GI tract, the lungs, and the exocrine glands. Oh my gosh. But again, the organs most responsible for drug excretion is the kidneys. That's why you want to be super careful and cautious if you have a patient who has decreased renal function. You're going to really need to monitor for medication toxicity in these patients. Now we're going to talk a little bit about factors that are going to affect all of these steps in the pharmacokinetic process here. So first we'll talk about absorption. Again, movement of the drug into the bloodstream, okay? Some things that are going to affect absorption. So first of all, route of administration, just like we talked about a little bit. Drugs are manufactured for a specific route of administration. So it could be oral, sublingual, buccal, an inhalant, topical, enteral, parenteral, and all of them are absorbed at different rates depending on the route. Okay, the form or the preparation of the drug usually is going to determine its route of administration. We know the fastest route of administration for absorbing is going to be the intravenous route. Another factor affecting absorption is going to be the drug solubility. So this refers to the ability of a medication to be transformed into a liquid form that can then be absorbed into the bloodstream. Okay, how quickly can this tablet get from tablet form to a liquid form so we can absorb it? That's essentially what this means. You have regular tablet medications that are going to take a certain amount of time, but then you also have things like enteric coated tablets, and we can talk about that more in detail later. But these particular drugs have a special coating on the outside of them, and this causes them not to be able to be decomposed by the gastric secretions, okay? That coating prevents the medication from being diluted before it reaches the intestines, okay? Whereas a normal tablet can dissolve in the gastric secretions of the stomach and then get working. Enteric coated tablets will live through the stomach, make it into the intestine with that coating on, and then it will be absorbed. In this way, the coating delays the action of that medication. Okay. It also decreases the irritating effects of that medication onto the stomach. So if you have someone who has a high risk for like GI ulcers or something like that, they may receive their medications enterically coated if they're offered in that way. There are also some medications that are timed release, or you may see them called sustained release tablets or capsules. These medications are formulated to dissolve slowly over a period of time, where it releases small amounts of the medication for absorption over a period of several hours. Whereas if you were to take a Tylenol right now, it was just regular, not timed release, it would absorb as soon as it gets into that stomach and starts getting dissolved. Whereas, like I said, these timed release or sustained release tablets, instead of releasing it all at one time, it will do it slowly over several hours. Another factor that can affect absorption is the pH. The pH, so we're talking acidity or alkalinity of the local environment, also is going to affect the absorption of a drug. So the acid content of the stomach is going to aid in transporting the medication across the mucous membranes. So acidic medications like aspirin are more readily absorbed in the stomach than basic medications or alkaline medications, such as sodium bicarb. Okay. Which those types of meds are more readily absorbed in more alkaline environments, such as the small intestine. Okay. And then lastly, blood flow. We talked about this a little bit already, but again, medications are absorbed rapidly in areas where blood flow to the tissue is the greatest. So the oral mucous membrane, super fast absorption because there's tons of blood flow there. Okay. In addition, areas with poor vascular supply, such as the skin or areas with lots of scar tissue, those areas are going to experience delayed absorption. Moving on to distribution. So remember, distribution is the drug transport to the tissues and the organs. Some factors affecting distribution. So again, I sound like a broken record, but local blood flow, okay? The rate of distribution is going to be dependent on the adequacy of the local blood flow in that target area, okay? Again, it's also influenced by that permeability of capillaries to the drug's molecules, as well as the protein binding capacity of that drug. Another factor influencing distribution, membrane permeability. So some drug molecules, they must leave the blood and cross a capillary membrane to reach their site of action. Okay, so some capillary membranes act as barriers, in fact. Like the capillary networks in some organs consist of really, really tightly packed endothelial cells that prevent some drugs from crossing them. And lastly, for distribution, the protein binding capacity can really factor into that. So a drug's tendency to bind to plasma proteins in the blood also affects that distribution. So for a given amount of a drug, some molecules bind to plasma proteins and the remainder of them will be free. For example, nearly all of acetaminophen or Tylenol molecules are free in the bloodstream and therefore they are pharmacologically active. Okay. In contrast, about 99% of the anticoagulant warfarin or Coumadin is bound to the blood. Its effects are produced only with the 1% of warfarin molecules that are freely flowing. Moving on to metabolism. So remember, metabolism or biotransformation. This is your chemical conversion of the drug, okay? So some factors affecting metabolism. First and foremost, where does metabolism take place? We know it's taking place mostly in the liver. So liver function is going to be a huge thing that's going to affect this particular piece of the puzzle, okay? So medications, as we know, it's not only in the liver, but it is mainly in the liver. So they can also be detoxified in the kidneys, the blood plasma, intestines, lungs, etc. But if your liver function is impaired, such as your patient has liver disease or they have cirrhosis or anything like that, the drug will be eliminated and metabolized more slowly and could possibly lead to toxic levels that may accumulate. Another factor is going to be health or disease status. So any type of disease state can also affect drug metabolism. Again, specifically in the liver, but also in multiple other areas as well, can all kind of go hand in hand to that. And then again, that first pass effect is also going to affect this piece. So remember, oral medications are absorbed from that GI tract and circulate through the liver before they even reach that systemic circulation. So many oral medications can be almost completely inactivated in this way. That inactivation is known as the first pass effect. For this reason, like I said, oral medications are formulated with higher drug concentration than are the same drug that would be given like an IV route. And then your drug excretion. So again, your body's elimination of that drug. The biggest thing that is going to have an effect on drug excretion is going to be kidney issues. So we just always want to be aware of our patient's kidney function. There's certain medications that are extremely hard on the kidneys or extremely hard on the liver. You really want to know these things so that you can take precautions and advocate for your patient when in regards to dosing or frequency or even necessity of those types of medications. So let's test your knowledge here. So the client has been on a low protein diet. This will most likely affect which pharmacokinetic process? The answer is distribution. So a low protein diet may lead to an inadequate level of plasma proteins, which will affect the availability of that free drug that's flowing, right? So now we'll talk a little bit about pharmacokinetics. So remember, pharmacokinetics is talking about what is happening to that drug once it gets inside the body. Where's it going? How fast does it work? How long does it work? Those kinds of things. So some terminology that you're going to want to become familiar with is listed on this slide. I'm going to go through kind of the definitions and some explanations of these things, but you need to be proficient in determining the differences between these things and knowing what they mean for your exams and for our in-class activities. So we're talking about the time until onset and then the peak action of the drug. So time until onset, that onset of action is that time needed for the drug concentration to reach a high enough blood level for its effects to appear. Okay, that's going to be your onset of action. This is also called the minimum effective concentration. So it ends up being like that smallest amount of drug that is needed to get to working on that whatever desired effect we're looking for. Okay, so that's that. When we talk about a peak level, when the concentration of a medication is the highest in the blood, that medication has reached its peak action. Okay, so again, I'm going to go through those one more time. So the onset of action is the time needed for the drug concentration to reach a high enough blood level for its effects to simply appear. Okay, then the peak is when those effects get at its very highest drug level in the blood. That is going to mean that it has reached its peak concentration. Okay. A therapeutic level is the concentration of a drug in the blood serum that produces the desired effect without toxicity. Okay, it's not too much. It's not too little to work at all. It's not too much to overdose someone. It is at the therapeutic level. Okay. There is also something called a therapeutic range. So this is a drug. The therapeutic range of a drug is going to be the range of that therapeutic concentration. Okay, so you'll see on drug labels as we go through learning our math, you'll see that maybe the therapeutic range for a toddler who weighs 40 pounds of this drug may be between 5 milligrams or 10 milligrams or something of the sort. And so that'll be listed on the drug label as like a therapeutic dosage range. Okay, and so there's going to a lot of times be a lower end of that amount. So it may say 5 milligrams per kilogram per dose, and then a high range. So 5 to 10 milligrams per kilogram per dose. And that would be like your therapeutic range for that drug. Again, coming back to that peak level. So remember, when we talked about peak, that is going to be the time when that concentration of the medication is highest in the blood. Okay, that's its peak action. So a peak level is going to occur when that drug is at its highest concentration. And when it's at that highest concentration, what's happening inside the body is that the rate of drug absorption is equal to the rate of drug elimination. Okay, so they kind of balance each other at that time until they get out of whack again, and that peak level starts to taper off and the medication starts to not work as well over time. As that drug moves away from its peak level and starts to get down towards the bottom where it's almost all the way excreted from the body, what that is known as is a trough level. So a trough occurs when the drug is at its very lowest concentration right before the next dose is due. Okay, so again, that drug absorption situation, the life cycle of a drug. So we've got our onset of action. That's when it starts working. That is when it is, producing desired effects. Then it goes kind of up a hill, as you can see on my slide here, all the way to the top to the peak. This is the most active this medication is going to be while it's in the system. And then it starts going down that hill until it gets to the lowest concentration, usually right before a next dose is due. So a lot of drugs, depending on how, some drugs that are like really critical require a peak and trough blood draw, okay, or a serum test, a peak and trough lab. And so what this does is they will draw a peak and they will measure and say, okay, is this within the desired range? And then right before that next dose is due, maybe 30 minutes to an hour before that next dose is due, they will draw a trough level. And so that will be, okay, this drug is almost out of the system. It's at the lowest concentration it will ever be in their blood. We're going to draw this lab and say, is this where we want it to be? Okay. Now, that is not our job as nurses. That's usually a pharmacist that's ordering those types of things. Vancomycin is a very common medication that uses peak and trough levels. But the point of that is so that the medication, the next time it is due, can be evaluated based on the patient's needs. So if their trough level was too high, they're probably going to decrease that dosage so they don't make the patient go toxic. Okay. They would do similar things when they do like TPN or total parenteral nutrition. They draw labs to determine what is the patient's blood sugar, what is the patient's protein level, what, a bunch of different things, vitamins and things like that, to determine how much medication or how much of those things to put into that next bag that they send up. So this is very similar. And the point being, we want to make sure that the medication we're giving is effective. And so that peak and trough level for certain medications is the way that we do that. Next, we'll talk about the half-life of drugs. So a medication's biological half-life is the amount of time that it takes for half of that drug to be eliminated or excreted from the body. Okay. For example, let's say we give tramadol. Okay. It's like a narcotic-like pain reliever. Let's say the half-life of that is approximately 6 hours. Okay. So this means if you take a 50 milligram dose at 8 o'clock in the morning, by 2 o'clock in the afternoon, half of that dose, so 25 milligrams, will still be left in your body. Okay? At 12 hours, 1/4 of that medication will still be in your body. So 12.5 milligrams will still be there of that initial dose. Okay? We know that elimination of that drug occurs in one of several places. So the kidneys for first and foremost and for the most part, right? But also the liver helps, the lungs help, exocrine glands, GI tract, all of that stuff. So if we have a disease process occurring in any of those places that help us eliminate drugs, we're going to have a longer drug half-life because excretion is impaired. So again, I stress to you, kidney problems, liver problems, those kinds of things can all have a big effect on how we metabolize and excrete medication, can cause lower doses or doses that are maybe too close together, given too often, to be toxic to a patient with those issues, whereas it wouldn't have been toxic to a patient without those issues. And then at the end of the day, the concentration of the active drug, so it's going to be that effectiveness of the medication, is going to depend ultimately on its concentration at that intended site of action. There are lots of factors that can affect pharmacokinetics and any drug's pharmacokinetics, and therefore its effectiveness and its safety is going to be affected by all of these. So first of all, age. Infants and little kids are going to require smaller doses of medication because their body size is smaller. So children dosing is typically weight-based. So that's where those problems will come in, where you will have a certain amount of milligrams per kilogram per dose, and you're doing weight-based stuff because they're small, right? The elderly also are going to have a lower functioning kidneys and livers for the most part, which is going to result in a lower excretion and a possibility of toxicity, longer half-lives of medication, things like that. So we want to consider age when we're talking about medication. Body mass or weight may also have a large impact on this as well, because medication dosages most of the time are calculated for an average weight of about 150 pounds. So your 450-pound bariatric patient may require a much larger dose to reach that therapeutic level. Gender plays a part in this as well. So hormones, body muscle mass, differences between fat distribution and water distribution. This is going to mean that the medications may affect men and women a little bit differently. Pregnancy is another thing. It's important for you to keep in mind that not all drugs can be given in pregnancy. They are all given a pregnancy class to determine its safety or its not safety in being given during a pregnancy. In that way, the FDA uses 5 categories to classify drugs based on their potential risk to a fetus during pregnancy. So a category A is going to show no risk to the fetus based on human studies. Category B is going to be no risk to the fetus based on animal studies, but no adequate human studies exist. Category C is going to be potential risk to the fetus based on animal studies, but still no adequate human studies exist. A category D is going to be positive evidence of risk to the fetus based on human studies, but potential benefits may outweigh the risk depending on why we're giving that medication. And then a category X means it is contraindicated as the risks of the drug outweigh any potential benefit that you could be giving this medication for. Any medication that is known to cause developmental defects to the fetus are called teratogenic drugs. Okay, teratogenic drugs should not be given in pregnancy, have a large risk to the fetus. They are to be avoided at all costs. The patient's environment. So remember, heat and cold can cause changes in that peripheral vascular circulation and can therefore cause changes in absorption, especially when you're giving topical medications. So we know that we're going to increase the circulation at a site when we apply heat, right? So the absorption of drugs is going to speed up if there is heat applied to a site. And the opposite is true for if a site is super cold. We know that there's not very good circulation there. The absorption and the pharmacokinetics of that drug are going to be hindered. The route of administration is going to be another factor. So if we're looking for local effects of a medication, those are going to be medications like, let's say, hydrocortisone cream, where we are trying to stop an itch. So we just put some cream on the spot that we want to stop itching. Okay, that's a local effect. Little to no absorption is going to happen because in order for it to absorb, remember, the medication has to go to the bloodstream. So if we're looking for a local effect, there's not going to be any absorption into the bloodstream because it's local right there on the skin where we're wanting it to work at, okay? If we want a systemic action of medication, that requires the drug to be absorbed into the bloodstream before it can be distributed to any other distant location where we may want it to go. So a drug may enter the circulation in a variety of ways. So by injection into a vein intravenously, right? Or it can be absorbed from other areas like the muscle, the stomach lining, mucous membranes, things like that. So absorption happens when we're looking at systemic effects versus local effects. And lots of things can kind of play into that piece of it. But we know that certain routes of administration are going to absorb a lot faster than other routes, and some go systemic and some do not. So we know IV is going to be the quickest way to get our medications to absorb. But also giving buccal medications in the cheek or on the gums, absorbing through that oral mucous membrane is also very quick because there's so much circulation there. Other things can go into that as well, such as, am I supposed to eat or drink with this medication? That can always affect absorption rates as well and can affect how this medication is going to work through the body. So therefore, the pharmacokinetics of this medication. Also, insufficient fluid volume can interfere with absorption, like dehydration, anything like that. Any type of pathological state. So we talked about this already multiple times. Diseases that cause any type of hepatic issues, renal dysfunction, circulatory volume dysfunction, things like that. Genetic factors as well. So different groups are going to respond in different ways to different medications. Okay, you can see in your book, it gives many examples. One specifically of Asian patients who may actually metabolize opioids at a slower rate than do other ethnic groups. And then lastly, there is always psychological factors. So anxiety may cause resistance to tranquilizing drugs, right? And then there's always something called the placebo effect. Okay, so if the patient thinks the medication is going to help, they will feel better even if the medication doesn't actually help. So we talked about pharmacokinetics. We've got that down. We know that the pharmacokinetics is what is happening to the drug in the body, the absorption, the metabolism, the excretion, the distribution, all of those things in our pharmacokinetics. Okay, we know about the onset. We know about the peak. We know what factors affect those things. Now we're going to move on to the second half of pharmacology, which is going to be pharmacodynamics, okay? So when we're talking about pharmacodynamics, the difference here is we're talking about the effects of the drugs, okay? So remember, pharmacodynamics is looking at how the medications achieve effectiveness by drug molecules interacting with whatever target cells we're trying to interact with, and the resulting biological response. So what happens once the drug gets to these places. And then we also, a piece of this is to evaluate our patient and evaluate their outcomes to that medication. When we're talking about evaluating the effects of these medications, so let's talk about a primary or therapeutic effect, okay? This is going to be effects that are predicted, intended, and desired. So these are effects that we want out of our medication. So in short, this is the reason that the drug is being prescribed, okay? When we're talking about palliative effects, these palliative effects relieve the signs and symptoms of a disease, but they have no effect on the disease itself, Okay, and that's a palliative effect. So, for example, giving opioid medications to cancer patients. It's not going to do anything to treat their cancer, but it is treating their pain, which is coming from their cancer. Next is going to be supportive effects. So these supportive effects support the integrity of the body functions until other medications or treatments can become effective. Okay, so for example, when I've got a patient that arrives in the ER that doesn't have a heart rate, we're going to treat the absence of the heart rate first, and then we'll figure out what caused it and then administer medications to treat that issue at that time. Substitutive effects replace either body fluids or a chemical required by the body for improved functioning. So for example, blood administration for a patient who has severe anemia or super low hemoglobin level. Okay. Then there's chemotherapeutic effects, which are going to destroy disease-producing microorganisms or body cells, such as antibiotics, anti-neoplastic drugs, chemotherapy, things like that. And lastly, drugs with restorative effects. So with that, these are going to return the body to or maintain the body at optimal levels of health. So for example, protein supplements to our patients who are at risk for skin breakdown or malnutrition. Now we know about all of our primary and therapeutic effects. Let's talk a little bit about secondary effects. Okay, so secondary effects are unintended, non-therapeutic effects of a medication. There are quite a few different kinds of secondary effects depending on what kind we're talking about. They can be predictable, they can be unpredictable, they can be harmless, they can be harmful. First, we'll talk about side effects. So these are unintended but often predictable physiological effects that are usually well tolerated by patients. Okay, so they're going to occur at a usual dose that is prescribed and can be immediate, like quick dizziness, or they can be delayed. For example, they get constipation. Okay, for hospitalized patients, you're most often going to see side effects caused by analgesics, antibiotics, antipsychotics, and sedatives. Those are kind of the big ones. The most common side effects of a lot of drugs are going to be your nausea and vomiting, diarrhea, dizziness, drowsiness, dry mouth, abdominal distension or abdominal distress, and constipation. The big thing to remember here is that side effects are unintended. We don't mean for these to happen. We're not giving the drug for this to happen, but they're often predictable. We already know that if we give this medication, this side effect is probably going to happen. For example, I give my patient IV morphine. I know that this is a potent opioid, and I know that it's going to cause a histamine response. Okay, so I will expect that this patient may come down with some nausea, maybe a little itching, some dizziness, some drowsiness, maybe a slight drop in blood pressure, and we need to monitor their respiratory rate because of this known side effect, right? So we're going to be on the lookout for those side effects because we didn't give the medication for this reason, but we knew that this was a possibility when we gave it. A lot of times people will use side effect and adverse reaction interchangeably, and they are not interchangeable, okay? The difference lies here. So when we're talking about adverse reactions, these are also unintended, similar to side effects, right? However, these are harmful and usually unpredicted, okay? Unpredicted, harmful, and unintended reactions to a drug that is administered at a normal dosage. Adverse reactions are more severe than side effects and often require discontinuation of the drug. Okay? The FDA defines severe adverse reactions as 1, they're life-threatening. 2, they require intervention to prevent permanent impairment or death. Or 3, they lead to a congenital anomaly, a disability, hospitalization, or death. Health professionals must document serious and adverse reactions according to their agency policy and report them to the FDA MedWatch program as well. So another example, remember that IV push morphine I just gave my patient? So instead of the typical side effects that we saw in our last example, this patient is complaining of their mouth swelling and then their blood pressure drops to 50/20 and they stop breathing. There's our adverse reaction. Then there's toxic reactions. So these are dangerous, damaging effects on an organ or on some tissue, a tissue in the body. So toxicity may be caused by any of the following. So first of all, overdosing. So we administer a dose that exceeds the prescribed amount. With examples including respiratory depression from excessive morphine or hypoglycemia from giving too much insulin. Okay. So those types of toxic reactions would be from overdosing. A toxic reaction can also be caused from accumulation of the drug into the tissues. So this is usually related to long-term use or incomplete metabolism or incomplete excretion of the drug. So it just builds up there. Okay. Or can also be caused by abnormal sensitivity or an allergic reaction to that drug. Allergic reactions as well are a thing we need to look out for when we're giving medication and as part of those pharmacodynamics. So medications most frequently implicated in an allergic reaction is going to be a lot of antibiotics, diagnostic agents, so contrast dye. Specifically, patients who are allergic to shellfish or iodine should not receive IV contrast for a CT scan or any other type of procedure. And then biological agents as well are high on that list of patients having allergic reactions too. The worst type of allergic reaction is going to be called an anaphylactic reaction. This is a life-threatening reaction that occurs immediately after administration of a drug. The pathophysiology here is that you're going to have a huge histamine response that affects the entire body. One of the biggest worries is the constriction of the bronchioles with edema in that larynx and pharynx. Because of the histamine response that occurs with anaphylaxis, you're also going to see a big drop in their blood pressure as well. If your patient doesn't receive immediate treatment, they will probably die. So typically your patient treatment for this is going to be epinephrine, steroids, antihistamines, and depending on the severity, they may need to be intubated. Next is an idiosyncratic reaction. These are unexpected, abnormal, and just simply peculiar responses to medications. So idiosyncratic reactions may take the form of extreme sensitivity to a medication, the lack of response to a medication, or a paradoxical, so the opposite of the expected response, such as if we give somebody a sedative, they get really agitated instead of really sleepy. You see this with Benadryl sometimes. And then lastly, a cumulative effect we want to know as well. So this is going to be the increased response to repeated doses of a drug that occurs when the rate of administration is greater than the rate of metabolism and excretion. Okay, so your book gives the examples of opiates and barbiturates. Another great example is premature infants. So they typically have lots of infections due to their immature immune systems and they receive antibiotics. One of those antibiotics that's frequently ordered is gentamicin. Gentamicin is excreted through the kidneys. So these preemie babies have an immature body system, and guess what? They have a tendency to not be able to properly excrete that gentamicin and end up with toxic levels that can actually cause hearing damage in these babies. Here is a table just showing some medications that commonly cause allergic or anaphylactic reactions. So you can see on here anything from aspirin to morphine to allopurinol, which we give for gout, down to iodines, histamines, things like that. So here's just a list for you to kind of look at. So just keep in mind when we're administering medication, a patient who's allergic to one drug may also be allergic to other medications in that same class, okay? And there's also cross-sensitivity reactions as well. So, for example, many patients who are allergic to penicillin are also allergic to cephalexin or any other cephalosporins because they're very closely related. So we want to be on the lookout for that. We always want to ask our patient about their allergies and about their reactions to certain medications. Okay, always remember to document allergies in the patient's medical record, on the care plan, and on the medication administration record. And as well, people with severe allergies or allergic reactions should wear a medical alert bracelet that identifies the person and the allergen and should carry an epinephrine pen or something of the sort for an emergency injection should they need it. So we're going to talk a little bit about drug interactions here. So we could have, or we could see, an antagonistic drug interaction. So this is when one drug interferes with the actions of another drug. And then because of that, this decreases the effects of the drugs. Okay. So that means the combined effect of these two drugs is less than if one drug was given alone, because they're kind of like fighting against each other. When we talk about a synergistic interaction, so with this one, there's an additive effect. So that means the effect of these two drugs given together is actually going to be greater than if the two drugs were given alone. And then we'll talk about drug incompatibilities. So with this, drug incompatibilities occur when multiple drugs are mixed together, causing a chemical deterioration of one or both drugs. The result is going to be an incompatible solution that should not be administered to your patient. You can usually recognize an incompatibility when the mixed solution takes on a changed appearance, such as a weird color, or it starts to clump up and crystallize, or something of the sort. However, you should always consult medication resources and compatibility charts before mixing medications. And then after mixing, make sure you're double checking the medication for changes in appearance. At the hospital, they have a system where you can put in the two drug names and then you can see if they're able to be given together. We utilize this a lot on the floor to see if I can give this certain medication in the same IV that some other fluid or antibiotic or something is running through. So drug abuse and misuse, you're going to want to be able to differentiate between all of these concepts here. So let's talk about tolerance. So tolerance is going to be a decreasing response to repeated dose of medication. So this person then requires more of the same drug to achieve that same desired effect that they've been getting the whole time. So they kind of build up that tolerance to this med. So for example, this would be our cancer patient who's needing increasing doses of opioids because they've been on them for so long. Or on the flip side, even a drug addict who has a long history with opioids. However, they come in and they have some crazy surgery where we know they're going to be in pain. They're going to need a higher dose of that same opioid to get pain control than would somebody who is opioid naive, so to speak. Dependence is going to be a person's reliance on or need for a drug. Okay, it's going to lead to compulsive patterns of drug use, where the user's lifestyle centers on procuring and taking that drug. When we're talking about drug misuse, we're talking about a nonspecific, indiscriminate, or improper use of drugs, including alcohol, over-the-counter medications, and prescription drugs, doing things with these drugs that we know we should not be doing. And then drug abuse is going to be the inappropriate intake of a substance by amount, type, situation, either continuously or even periodically. Unfortunately, nurses have a high level of drug abuse. The State Board of Nursing has been doing a lot of research and creating programs to help peers identify abusers, as well as getting help for drug abusers as well. The federal agency that handles drug investigations is the US DEA, or the Drug Enforcement Agency. And then illicit drugs, these are known as street drugs, so drugs that are sold illegally. Many are prescription drugs like hydrocodone, oxycodone. They are sought after, highly sought after for their mood-altering effects. But also prescription drugs can be abused when being taken for purposes that are not medically intended. An important part of administering medication is measuring and calculating drug dosages. So medications, as we know, are not always available in the exact dosage for our patient needs. Sometimes they're ordered in milligrams and we get micrograms on our label, things like that, and it requires some math on our part. So we've already kind of been working through this, and we will only continue to build on this math in this class. But it's super important that you're proficient in math by the end of this class, because it only builds and builds as we go on. So now we're going to talk about how to take medication orders, special considerations regarding that, and then medication errors. As much as we don't want it to, errors happen. It's human nature to make an error sometimes. All we can do is follow these rules and steps located in this PowerPoint to do the best that we can to safely administer medications to our patients. As nurses, we cannot write orders for patients. Okay, we cannot prescribe. However, before administering any medication, we have to obtain a prescription or an order from the licensed care provider, and that provider has to have prescriptive authority. But it is our job to verify that the order that we get is complete, correct, and legible, especially if it's handwritten. For inpatients in the hospital, these prescriptions or orders for medications are either entered into an electronic health record for automated dispensing from that Pyxis, or in some places they'll be printed in a medical prescription section of a paper medical record as well. For an outpatient and for medications that will be filled by the patient after they leave an inpatient stay, the prescription is written and then given, or I guess sometimes you see it printed with a printer as well, but then it's given to the patient or family so that they can take it to the pharmacy and have it filled, or sometimes the physician or provider will call the medication into the pharmacy so they can get it when they leave. Our big job is making sure that the order is correct and we have all pieces of this order before the patient leaves the hospital if they're going home and they need to get medications for home, or to make sure that if we're taking a verbal telephone order, however we may be getting the order, we have to make sure that it is complete and correct. Okay, so components of a medication order, we have to have the client's full name. Okay, we have to have the date and time of the order, the name of the medication, the dosage size, the frequency, and the number of doses. So that means however many milligrams, micrograms, grams, whatever, that would be your dosage size. Frequency, how often are we giving it? Every 2 hours, every 3 hours, every 4 hours, every day, etc. And the number of doses. So how many, if it's an antibiotic and they only need 10 doses for 10 days, then it would just be dispense 10, right? You can see actually on this prescription pad picture I have here that at the bottom it says SIG number 90. So that SIG, you don't see that a whole lot anymore, but that used to be short for some word in Latin, like signature or something like that, some signature type word in Latin. And all that means is that these are the instructions here that we want you to print on the drug label. Okay, the number 90 there is telling the pharmacy how many to dispense, so the number of doses. Route of administration must be on the order as well. You can see on this pad over here that route of administration is PO or by mouth for this person. And then the printed name and signature of the prescriber, including any relevant credentials and legal registration identifier or DEA number. So if it's a narcotic, they would have their DEA number on there. Otherwise, they definitely would not fill that. But all of these things have to be on an order for it to be true, correct, and complete. If your provider gives you a verbal order of some kind or even a written order and they forget any of these things, you have got to call and clarify because that is our job when taking an order. You guys will be able to find this table in your book, and these are medication-related abbreviations. These are extremely important to know. You need to know all of these just in your everyday nursing practice, but also for your test and for any quizzing or medication checkoff in this class. So you need to get familiar with these if you're not familiar already. So lots of different types of orders. It's important for you to know the difference between these. So when we're talking about a written order, so these are applied by a physician or provider without a renewal date until the prescriber writes a prescription to either alter or discontinue that original order. An automatic stop date order, so this is going to be a protocol that hospitals use for discontinuing medications after a certain length of time. So most narcotic prescriptions are only in effect for about 7 days. If the medication is needed after an automatic stop date, the provider must write another prescription. Then there is a stat order. So this means that a single dose of medication is ordered to be given immediately, so right now, and only one time. So these stat orders do not go on to be given every so often or a specific length of time. Like it is one time give right now in an emergency. Then there's a single or a one-time order. So this is going to indicate that the medication is to be given only once and at a specified time. You'll see these types of orders like before surgery or before a diagnostic procedure. So for instance, when I worked OB, right before we did C-sections, we would give our patients Bicitra, which was to decrease stomach acid to prevent aspiration during surgery. So an order, a single one-time order for that would read like Bicitra, 10 milliliters, PO, at 8 a.m. or maybe 30 minutes before they get to the OR, times 1, and then that would kind of handle that, right? And then a standing prescription, or a standing order. These are an officially accepted set of orders that can be applied routinely by nurses for the care of patients with certain type of conditions. So for instance, these are like your protocol orders. So you have a patient who you check their blood sugar and their sugar's 32, right? Do we have time to go call the doctor for an order right now? No, we need to get our patient back to the land of the living, okay? So for that reason, most hospitals will have a protocol that will say something like, if you have a blood sugar that's less than 70 or less than 50 or whatever it is, give this much IM glucagon and then call the provider afterwards. So that's a standing order. And then a PRN prescription. So this is going to be something that requires the nurse and the patient to kind of collaborate on when these medications are given. So the physician will specify the condition for which the med is to be given. So let's say it is a nausea medication. Give if the patient has nausea, right? That's what the order has to say in it. And then it also has to give a minimum time interval. So it can only be given every 4 hours or every 6 hours, okay? So when we're determining whether or not to give a PRN medication, we need to know that PRN medications cannot be given any more frequently than what they are prescribed. So if they're only every 4 hours, that's how often we can give it, no exceptions, okay? Even if they continue to have symptoms. Okay. Typically, you'll see PRN medications will be things like pain medication, antiemetics or nausea medications, and then laxatives as well. And then communication of orders. So how is our provider going to communicate orders to us? So our orders can be handwritten. So the order is either handwritten on a prescription form, or it could be like pre-printed on like some computer paper that they print out, something of the sort, but it can be delivered to us in that way. It can also be delivered to us orally. So when you receive a verbal prescription, you as the RN are going to write the prescription and sign it with the provider's name. And then you're going to follow that with your name and your credentials as well. The same goes for receiving orders by telephone. So usually if you're receiving an order by telephone, this is usually like in response to a call that you've placed to them about maybe a condition change on your patient, or maybe there's been some lab results that have come in that they want to order something for, something like that. Either way, whether you are receiving an order orally or by telephone, you have to repeat and verify the order to your physician. So your physician says, or your provider says, hey, I want to give 10 milligrams of morphine times 1 now, IV, right? And you would repeat that back, and then you would wait for them to say to you, yes, that's what I said, okay? And then the most important step of that is to document that that's what you did, because that's what's going to save your bottom in court. Okay, so make sure that anywhere that you're typing that out or writing that out, what order they said, you always put RAV for repeated and verified, or VRBO, verbal, VORB, verbal order readback. Those are two that I've seen in real life, or you could just write it out, whatever it is. But you want to make sure that it is known that you did that step, okay? If you have a patient who is giving you if you have a provider who is giving you a verbal or a telephone order, the physician or provider has to co-sign those orders within 24 hours. A little bit more about verbal and telephone orders. So when we're talking about verbal orders, so this can be abbreviated V.O. verbal order. These are spoken to you often during a client emergency, but also can just be a doctor who maybe doesn't want to put in their own order. That happens from time to time. They should be made more for critical change in client condition. However, we take them more often than that for sure. Telephone orders, abbreviated T.O. You may even hear them called TO on the unit. These are received by phone and then are transcribed into a provider order sheet. Again, verbal orders and telephone orders are both at high risk for error because it's all based on what we hear. And the look-alike, sound-alike medications, things like that get in the way. Human error gets in the way, okay? A couple rules when we're dealing with verbal or telephone orders. We are only writing prescriptions if we heard it for ourselves, okay? We don't want to go through the game of telephone because we know how that ends up, right? We want to make sure that the verbal prescriptions make sense with the client's status, okay? So again, we're the last line of defense here. So we have to make sure, does this order make sense for this particular patient, how they're presenting, and what are their assessment findings? Okay, that's on us. We have to always repeat the prescription back to the provider to confirm accuracy. This goes for telephone orders and for verbal orders as well, okay? We always spell unfamiliar names when we're talking to the provider on the phone. Did you say morphine, morphine? Or, some other words may sound similar. So we want to make sure that if there's something that you're not sure of, say, hey, can you spell that back for me? And then also pronounce digits of numbers separately as well. Directly transcribe whatever order you get into the patient's chart. We have to include the date and time. We have to include the text of the order. So all the things that an order requires. So what's the name of the medication, the dosage, the frequency, the route, all of that stuff. And then at the very end, we're going to put the provider's name. We're going to put our signature. We're going to put that it was a telephone order or verbal order, so TO or VO. And then we're also going to note down there, and this is super important, we're going to note that we verbally read this back, or we read it back and verified that this was the correct order, okay? Again, providers must countersign the verbal order and the telephone order within 24 hours of it. All right, we're going to test our knowledge here. So the nurse is having difficulty deciphering the medication prescription written by the provider. What is the best strategy to clarify the information? We can only get what the provider means directly from the horse's mouth, and that is the provider. So we have to call the provider and ask them to clarify their prescription, okay? But I'm going to throw you a curveball here. So let's say that you've called the doctor and he is not very helpful at 2 in the morning and tells you to do what was ordered and stop bothering him. What is your next move? So for this, and this isn't unheard of, most of the time this doesn't happen, but it can. So we want to make sure, what do we do when our doctor or our provider is not being supportive when we have a concern that we're bringing to them? So next move, we're going to move up that chain of command with our concern. We're going to go to the charge nurse, we're going to go to the house supervisor, we're going to go to the unit manager, probably in that order. Whoever is your point person, your direct supervisor, okay? If this happens, this should be an incident report. Physician incivility causes errors because nurses become afraid to clarify and collaborate, okay? The person who's going to lose in this situation is going to be the patient. So it's super, super important. So medication errors. Can you believe that 1 in 30 patients will be affected by a medication error? That is crazy. There is a lot of things that goes into a medication error, and so here is a lot of the things that can contribute to making an error on our units in our busy workday. So first of all, lack of knowledge or information. So lack of knowledge of the drug, so maybe incorrect dosages, we don't know our correct dosages. Maybe we didn't know how to mix the med, we mixed it incorrectly, we gave an infusion too fast, we gave 2 drugs that don't interact well and they've crystallized and caused a problem. We don't know our adverse effects. We gave somebody a cephalosporin who's allergic to penicillin, those kinds of things. Or a lack of information about the patient is another big cause. So do we know that the patient has allergies? Do we know their lab results? If we're giving potassium to a patient, do we know that their potassium is low? What if their potassium is high and you give it? These are things that you need to know and check before you give these medications. Medical condition for which the medication is contraindicated. Do you know? Do you know if that medication is contraindicated? Those are the second most frequent causes of errors, okay? Or another frequent cause of error, type of error is a drug given by the wrong route. Okay, we never, ever, ever want to administer a medication that we don't understand its usage. Okay, so even if we don't recognize a med that we're about to give, we have got to look it up before we start giving it. Okay, there's so many easy ways to look up medications now. Most EMRs have a drug library. You should always have a current drug reference book on you. You can always call the pharmacy. Another common cause of medication errors, so faulty communication. So the written prescription may be unclear or illegible. You can't read it. Maybe it's transcribed incorrectly. Somebody meant to write 16, but they wrote 61, right? Maybe there's confusion between drugs that have similar names. Maybe somebody didn't spell out the confusing things that they got on their telephone order. Okay, so a telephone order taken incorrectly. Maybe a protocol is not understood or it's violated in some way. Maybe a drug was transcribed and the order was written in the wrong patient's chart. Maybe it was the wrong dosage because they misplaced the decimal point, or they they left a trailing zero, or they didn't put a preceding zero. Maybe abbreviations are misunderstood. Maybe there's poor or no documentation. Okay, maybe somebody thought, oh, they didn't chart that medication, so they must not have given it, so I'm going to go ahead and give it. But what if they actually did give it? They just didn't chart it. Equipment errors can happen as well. So the wrong equipment is used to administer the drug, or the equipment malfunctions and is not used properly, like a barcode scanner. So we keep skipping that, and you'll see some errors that we'll talk about in the coming weeks where these are true and valid concerns. Calculation and measurement errors. So an error in calculating the dosage is made, so the patient receives too much or too little of the medication. Okay, or maybe there's confusion in the unit of measurement. For example, if a drug is prescribed based on the patient's kilograms, but it's dispensed or it's administered based on the patient's pounds. Those could be two very different orders. Okay, and then some other things. Maybe medication is improperly handled or improperly stored, so it's ineffective. Maybe the patient's identity is not checked and the wrong patient receives that medication. If your lighting in your room is not adequate and you can't really read the label the best that you could, right? Maybe the nurse is tired. Maybe they're distracted. Maybe they're interrupted. Maybe they're sad. Maybe they have something going on at home. They're distracted, right? Another big thing, leaving medication on the bedside table and charting that it's been given. What can go wrong with this? I'm here to tell you a ton of things, okay? The patient may forget to take the medication, even though the MAR says that it's been done because maybe you've already charted it. The wrong patient could come in. A wandering Alzheimer's patient could come in and take that medication. Somebody might steal the medication. Maybe the patient has a family member that really likes whatever drug you just left on that table, okay? Lots of things. So we always, always, always visualize our patient taking the medication. Never leave the drugs at their bedside. There is some technology out there that was made to help us prevent these errors, and it can be really, really helpful, but when it doesn't work or we get too much of a hurry to bypass these safeguards, it becomes a big, big problem. So a couple things that help us. So computerized prescriber order entry, or CPOE. So this helps prevent errors in transcriptions due to illegible handwritten prescriptions. Because the electronic prescribing systems, the physician or the provider puts in their own orders instead of telling the nurse to do it and then going through an alternate party, right? These systems are safer when combined with decision support tools that automatically alert prescribers to drug interactions, allergies, and other potential problems, which is helpful. Another safeguard is going to be barcode medication administration. Super great. We love barcode medication administration, especially when combined with the CPOE. It provides a highly effective system for identifying the right patient. It transfers data electronically, eliminating the error-prone paper transcription process. And when it's used correctly, barcoding at the unit dose level prevents nurses from selecting an incorrect medication. So you've got the barcode scanner, you have your patient's ID badge, which you verify by scanning their ID badge and scanning their medication. If you're in the wrong chart, it won't let you scan the medication. If you scan too much or too little of the medication, it'll alert you. So it is it has prevented so many errors when used correctly. And then there's smart IV pumps, which are awesome. So smart IV pumps can help you avoid programming the wrong dose into the pump to ensure that the correct dose is delivered over the correct rate. Okay. Once it's programmed, the delivery rate doesn't change and an alarm will sound or the pump will stop if the nurse attempts to program something outside the dosing limits, or if the flow is interrupted from like a blocked line or a kinked line or whatever it is. Okay. A lot of these smart pumps nowadays are also have what's called guardrails in there, which is really awesome because the pharmacy will input the most commonly prescribed medications on that unit into those IV pumps, and the dosing will kind of already be there, which again takes an additional precaution because it takes away from the human error of it all. And then automated dispensing cabinets, so like your Pyxis or your Omnicell we talked about a little bit. This is going to minimize human handling of drugs in the pharmacy and are known to reduce medication errors when the built-in safety features are used. The problem comes from when the built-in safety features are not used and when we get too comfortable that the right medication is going to be in the right pocket, because so often I see med errors that happen where it's because the wrong medication was loaded in there. So we have to do our checks when we're in there. We can't rely on technology so heavily that we stop using our brains. And then lastly, you want to use your patient. Okay, patients are typically pretty smart about what they take. So we're going to use them as a resource. Okay, don't let the technology make you forget the last safety check is your patient's understanding of their medications. Okay, we want to make sure that they know what they're taking. We want to make sure we explain to them what they're taking. Okay, if the patient says they don't know that, like, hey, this medication or this pill doesn't look like what I take at home, we're not going to patronize them. Okay, we're going to do some research. This is a good time for us to stop and say, okay, I'm going to look at that, because what the patients a lot of times will catch their own errors if we listen and we don't act too smart for them. If you commit a medication error, so the very first thing that you have to do is we need to assess our patient. This includes vital signs and any assessment for negative effects, right? So we should all know the side effects of any medication before we give it. So we need to look and make sure, what are we giving this medication for? What side effects can we expect if we give too much? We should know that if we give too much insulin, we're expecting their blood sugar to drop. We should be monitoring that blood sugar very actively. Okay, so that's first and foremost what we need to do. Okay, next we're going to notify the physician or the provider and the charge nurse as well. Okay, notify that nurse manager of your unit. Report the events surrounding that event is going to be the next thing that we're going to do. Okay, we're going to make sure that we're also following any orders that the physician or the provider prescribes related to this incident. So maybe the patient is transferred to ICU. Maybe we needed to get a certain amount of labs or take a certain amount of blood pressures in a row or whatever it is. And then we want to make sure that we are also always going to document the medication in the MAR, making sure that we are including the dose that's given. For example, I gave 10 milligrams of IV push morphine instead of 1 milligram. So in the MAR, I'm going to document that I gave 10 milligrams, okay? Factually, I will document that I gave 10 milligrams. However, we will never ever document in the chart that a medication error was made. We will never write a narrative note that says I made a medication error, I gave 10 milligrams instead of 1 milligram. We're not going to do anything like that in the patient's chart. We're just going to chart that we gave the amount of medication that we did, the truthful amount of medication that we did, okay? Instead of documenting that, we are going to complete an incident report, okay? We're going to complete that incident report. This is where the mistake portion is documented, and everything surrounding the mistake is used as an internal tool for a quality improvement program inside the facility. Okay, so this is also where you need to review your mistake and determine how and why it occurred and how we can prevent such a mistake from ever occurring again. There's been multiple medication errors that have happened where it has been as a result of a systemic error, some kind of error in the flow of how things move in the facility, and things have been changed, or even like packaging errors, colors of needle caps, things like that have been changed over time because safety issues have arisen. So being honest and really reflecting on why did this happen can be very, very helpful for patients in the future to not have the same error done to them. All right, let's talk about the medication administration record, or the MAR. Anytime there is a provider order for a medication, it flows onto the MAR, or the MAR, or the medication administration record. So this is something, it can be computerized, it can be on paper, but some way or another, there's going to be a MAR for us to reference when we're giving medications. The MAR is going to have a comprehensive list of all of the patient's prescribed medications. So this is everything that they get in an entire day, whether it be something that's scheduled every 4 hours, once a day. PRN medications will be here, any type of continuous IV fluid, IV push medications, any IV piggybacks, antibiotics, any medication, no matter how, if it's a one-time order, stat order, it will all show up here on the MAR. And it will flow in from either the provider putting in that order and it will flow to the MAR, or if you're in a place that uses paper, it'll be transcribed there from sometimes the nurse who will receive the order, transcribe it onto the MAR so that it's given to the patient when it's supposed to be. Once the medication order is in, it's timed, and so you'll be able to look at the MAR and it will show a given time, and then it'll show like 9 o'clock, and then all the medications that are due at 9 o'clock, 10 o'clock, all the medications that are due, so on and so forth. So all the medications on there are timed. The ones that are not timed are going to be like your PRN ones that are like, give this every so often. So you can give it anytime as long as they haven't had it within the prescribed amount of time. If they've had it in the last 4 hours, they can't get it again, right? Allergies are always listed on the MAR, whether it's paper or electronic. This makes them easily visible for caregivers who are prescribing and also those who are administering medications. That's a vital step before we administer any medication, is to check the allergies of the patient. And so when we're thinking about the MAR, this is basically what we are looking at. This is the gold standard, our Bible. This is what the physician or the provider has ordered for the patient to have in a 24-hour period, okay? This is where we are going to do our 3 checks for our medication administration, which we'll learn about in a minute. But when you see all of those math problems on your exams or on your practice sheets that talk about an order versus a supply, the order and the problem is what you're getting from your medication administration record, and your supply is going to be your drug label. So when we talk about passing medications and doing our safety checks, we're talking about taking the drug label from whatever drug we're about to give and comparing it to the MAR so that we can make sure that these 2 things match and we're giving the patient the right med, the right dose, the right frequency, the right route, et cetera, et cetera. The other big piece of the medication administration record is not only to guide us on what medications to give, but also it allows us a place to document the medications that we have given the patient and a reference so that we can see when the patient's received the last dose of this PRN medication, or we can see, did they get their 9 o'clock dose of whatever, right? So should something come up where your patient refuses medication, which they are always able to do, if they do refuse, it is so important for us to make sure that we note that refusal on the MAR somewhere. Most of the time you'll be able to click somewhere and it'll show a client refusal. You'll be able to chart the reason and things like that. But it's just always important to understand that other nurses who come to work after you are going to be referencing this MAR when they are determining if it's safe for them to give their patient another dose of medication or something. So if you are omitting a medication, you're deciding to withhold it because maybe the patient's blood pressure was too low, or maybe your patient's gone for surgery, or maybe your patient refused, whatever it is, it's super important to not just leave that blank with no acknowledgement and no reason and no charting for that, because the person who comes on after you may be going back to look at your charting, and if you either leave it blank, they may, which they shouldn't, but they may say, oh, well, they must have just forgot to chart it, and then assume that the patient got that medication. And if it's an essential medication that maybe was withheld because they were at surgery, maybe they should have it later, that's something that we should follow up on. And this can be a big cause of medication errors for people, double dosing people. If you're not charting what you are doing with the patient, why you're withholding, things like that, it can really cause a mess. This is actually an example of a MAR, and it's actually a screenshot taken from the software system Cerner, which you guys will use at Ball when you go for your clinicals. And so kind of when we look at this, most MARs, they all have the same kind of components. They all look a little bit different, but they're all going to be very similar in this way. So when we're looking at this, we can see that over to the left-hand side, noted by the number 1, it's got the MAR. So you click that, that's going to take you to your MAR. Okay, you can see the MAR there in the middle of the screen. Off to the left, you can see that you can categorize your medications. You can choose to show scheduled meds versus unscheduled meds, PRN meds, continuous infusions, medications in the future, or anything that's been discontinued. Okay, and as you can see, all of those are checked. So the person that's looking at this MAR is seeing everything that's ordered for the patient and everything that has been ordered, discontinued, all the things. Okay, so you can see here that your patient has scheduled acetaminophen, 325 milligrams, PO, QID, so 4 times a day. It's a tablet, it has a start date on there. And then it also has a special note there that you can see, kind of cuts off, you can't see it all. But if you were to hover over that with your mouse, it would bring up a big text box where you can read all of those special instructions. And it's super important to do that piece because that's where you're going to find things like, for instance, with this med, don't exceed 4 grams in 24 hours because Tylenol can be toxic in that way. And this is also where you'll find things like, don't administer this medication if their blood pressure, systolic blood pressure is less than 100 or whatever it is, giving you some warnings of when to not administer those meds. So it's important that we know that. So you can also see up at the top in the blue, you can see that your patient's name is Critical Care Nurse Bobby. Right below that, you can see that they have no known allergies. And then off through the rest of that, you can see their date of birth, their age, gender, medical record number, all the things over there, code status, weight, anything that you should need to know is going to be up there. And that's going to help us double identify our patient when the time comes to pass these medications. But this has everything that we need. You can see down on the MAR as well where it shows you the acetaminophen order. You can see the columns are by time. So you can see a 6 a.m. column, a midnight column, a 2200 column, a 2100 column, those kinds of things so that we know, okay, right now they have acetaminophen scheduled right now at 5:00 p.m. on July 1st, 2020. And that is going to tell us, okay, we need to give that medication. And once you get into the MAR, you'll be able to see that it is color coded. So you'll be able to see red is past due and things like that. This gray means that that has either been given or it's discontinued. It kind of depends on what the color coding is. But yeah, you'll get familiar with that as you work through those programs. The first step of our nursing process is always assessment. So before we do something, even as mundane as it sounds to give meds, we do it all the time. It's a huge pillar of our job. We still need to do an assessment every single time before we give a med. It may not always be a full head-to-toe assessment, but we definitely need to do a focused assessment, and that's why it's so important to know those side effects, know what this drug is planned to do, so that we know what is the pertinent assessment we need to check before, after, how do we check to see if our patient's having a side effect or an adverse reaction, those kinds of things. So before administering medications to patients, first thing we're going to do, always check our patient's allergy list, okay? Also verify with your patient, ask them their allergies as well. We're also going to measure vital signs. There's a lot of medication out there that's going to have some kind of effect on a vital sign of some kind, whether it be intended or unintended. So we want to make sure we have a full set of vital signs before we administer medications. We always want to assess whether our patient is their general condition appropriate for the medication? So that's where those side effects come in. Do we know that if we're giving our patient insulin, do we know what their blood sugar is before we give it? If we're giving our patient a cardiac med, do we know what their blood pressure is or what their heart rate is before we give it? If we are giving a blood thinner, is our patient about to go to surgery? That would be important to know. Do they have bruising all over their body? That may be something that would cause us to hold the medication or at least contact the provider. So is their condition appropriate for the medication? We're going to evaluate our knowledge of the medication. That kind of goes into knowing what are your signs and symptoms? What is the reason you're giving it? Are you familiar with this medication? If you're not, get familiar with it. When we do get to the bedside and we're preparing to administer these meds, we want to make sure that we're assessing our patient's mental status. So do they seem with it, or do they seem like oddly confused? That's not per their baseline. How's their coordination? Are they giving you any kind of red flags that are showing that maybe they've got something going on where maybe we should not administer this particular medication, right? We want to also assess their ability to self-administer. How's their swallowing? Can they swallow? Do they have a tube? Do we need to change the route of this medication? Is it appropriate for them to take this oral medication? And we always want to make sure, is the head of the bed up? We want to make sure that we're not going to, give somebody medication lying down or give them water lying down so that, we increase their risk for choking or aspiration. And then after we medicate our patient, it's always our job to evaluate the effectiveness of the drug. Okay, that's one of those things that nurses can do that the techs and the CNAs cannot do. Reevaluate our patient. So was the drug effective? Are they experiencing any side effects, and do they have any signs of adverse reactions or toxicity? So we should always have that on our mind after we give medication to our patient. And then should your patient be coming in and we need to take a medication history, that's an important piece of the puzzle as well, where we want to make sure that we're exploring all surfaces of their medication history. So do they have, what's their allergy history? What kind of reactions do they have to this allergy? What kind of treatment did they need to get rid of the symptoms of that allergy when they had it? We should also ask about our patient's history of illness. What's their attitude towards taking medications? Do we feel like they're compliant? Are they non-compliant? Do they have any learning needs or learning gaps that we've identified? And then super important, we want to make sure to ask our patient if, are they pregnant? Are they breastfeeding? To determine if the medication is appropriate for them. Okay. It's also important to check any relevant laboratory results and obtain a current list of medications that they're taking at home, including those over-the-counter medications and also including any like complementary or alternative medications as well. Super important to keep an eye on those laboratory findings when you are taking medication or giving medications that we know can have an effect on that. So we know that when we give a patient furosemide or Lasix, if you've ever heard of that, furosemide decreases the potassium level in the blood. So much so that almost every time a patient is ordered furosemide, they are given a potassium supplement. So that is pertinent information to know anytime you're giving a patient furosemide. So checking lab results to make sure that medication is appropriate is key. And then exploring, if your patient is a non-compliant person with their home medications, why is that? Can they not afford their medications at home? Is there some resources we can point them to? Those kinds of things. And then also taking into account before administering medications, we kind of touched on this earlier, but the physical examination of the patient. So going back to our patient who's getting a blood thinner, are we going to, if we do an IV assessment on that patient and we see that their IV is oozing blood, maybe giving them a blood thinner is not such a great idea. It's something that at least deserves another look and a conversation maybe with the provider. So anytime we are giving medication, we have to do 3 checks of that medication, okay? That is our due diligence as nurses, do our 3 checks to make sure that we are giving all of the right drug to the right patient, the right dose, the right time, the right route, using the right documentation, all of that, all in an effort to prevent medication errors and not kill people, right? So when we say we're going to do 3 checks, so your first check is going to be before you pour. Okay, so we're going to check the medication label against the medication record. So again, taking that medication record, checking it against the label that you have to make sure that we are either drawing up or giving the right amount of tablets or, pouring the right amount of liquid, whatever it is, that check is going to be done before we pour. So we're just looking at a drug label at this time. Typically, this first check, if you are working with a Pyxis or an Omnicell or something like that to get your medications out, this first check is happening right there to make sure you're pulling out that right medication. Then when we get to that bedside, we are checking that same med that we just checked at the Omnicell or the Pyxis, and we're going to check it against the medication record in the room of our patient. Okay, so that's before you pour. Your second check is going to be done after you pour. So you've already verified that you've already done your first check. You know that the labels match. Now you're going to go ahead and prep your med. So pour it in the medicine cup or draw it up in the syringe or whatever it is, and verify once again that the label and the MAR match and you're drawing up the correct med and checking your 6 rights of med administration, which I'm going to talk about here in just a minute. Okay. And then at the bedside for that third one, which sometimes, number 2 is done at the bedside as well, depending on kind of the setup of your facility. But again, we're going to check it lastly right before we give the medication to our patient for the third time. So in an attempt to prevent medication errors and keep our patients safe, we have 6 core rights of medication administration that we need to know, memorize, follow, and check every single time we are doing our 3 checks for the MedAdmin, every single time we are pulling, prepping, or giving medications. So those 6 rights, basically they encompass the fact that we are giving the right medication to the right patient in the right dose, using the right route at the right time with the right documentation of med administration. The list of rights just keep on going, but it's just a way to kind of enforce the rules of MedAdmin to you. So some other rights that you'll need to know is the right reason. So this includes the right to not receive any unnecessary medications. Okay, for example, a tranquilizer or a sleeping pill should be given to the patient who is very anxious or cannot sleep, but not for the convenience of caregivers who are weary of their excessive demands. Okay, so giving drugs for the right reason. Okay. The right assessment, we talked about that already, but we need to make sure that before we're giving medications, we're doing the right assessment. So is this medication appropriate for this patient? And then after we give it, the right assessment. Was this medication effective for this patient? Do I need to see if we can get the dose increased so that we can get appropriate pain control? Or do we need to see if maybe we can get this decreased because they're having too much of this, that, or the other, right? So the right assessments before, during, and after med administration. The right to know. So this is important because patients have a right to know the name, everything about the medications that you're about to give them, okay? It is inappropriate to make patients feel like, first of all, they can't ask these questions or make them feel like they're questioning you and your skills because they ask questions. I would ask a lot of questions if someone was giving me meds right now. So you need to be confident enough in your abilities to explain and teach with these medications and identify them as well, and know the reason why you're giving them to the patient, because if they ask, they have a right to know. Right evaluation, we kind of already talked about this with the right assessment. So just making sure that whatever the med was supposed to do, you are making sure that it did its job after you give it. And then lastly, the right to refuse. So that patient always has the right to refuse a medication regardless of their reasons and regardless of the consequences. Okay, it's our job to educate the patient the best that we can. And if they still refuse, that's their right to do so. We need to make sure that we are keeping our pediatric patients comfortable as well. So here's some considerations that we want to make sure that we're aware of when we are dealing with kids. So we want to make sure that we're minimizing distress for pediatric kiddos through atraumatic care. Okay, this is going to involve doing interventions like creating a safe space for them, being nice and kind and warm and welcoming. Okay, allowing their parents to stay and be involved. So allowing them to maybe sit on their parents' lap while they are receiving whatever treatment or assessment or whatever it may be. So prevent parental separation. Allowing for play therapy. So, allowing young children to touch the equipment, to have a special toy with them, whatever it is, they really learn through playing. So, a lot of times, if they're confused about what may be about to happen to them and you're trying to educate them, maybe doing something like showing how you're going to give the doll a shot or something of the sort, and then allowing them to kind of be a part of that. Again, allow them to explore the equipment, show them maybe the thing that you're about to put in their ear, or show them the tongue depressor, or show them anything that they can get their hands on to become more familiar with is going to be beneficial for them. Give them simple choices and use techniques to mask the taste of medicine if you can by putting it in juice or just allowing them to not absolutely refuse the medication because it tastes so bad. And then, as always, encourage and allow them to ask questions if they're feeling unsure. So we're going to talk about the different routes of medication administration. So with this, your book lays out in great narrative detail all of these routes. However, I would suggest flipping to the back of the chapter where it goes through the procedure for each route. I would study those. You're going to need to know those for your exam. So first, oral medication. So we're talking tablets, capsules, liquids, those kinds of things can be given in an oral route, okay? So the routes for oral is we're not only talking about taking a medication and swallowing it when we're talking about the oral route. There is other ways that we can give medications that also classify as the oral route. So with this, we can do a buccal medication. So that is where we allow the medication to dissolve in the cheek. And then sublingual medications, which is where we put the medication under the tongue, okay? Again, your oral cavity is so vascular, absorption is so fast in these ways. And then there's also enteral medications as well. So for patients who cannot swallow or who have feeding tubes, we can give oral medications through an enteral tube. So remember, enteral, all that means is that it bypasses the mouth, okay? For that. So it may go through an NG tube or through a regular G tube or a jejunal tube or whatever it is. We can give those oral medications via that route as well. So tablets, you can see a picture on your screen of a tablet. So when we're talking about tablets or capsules are the ones that have, like, you can pull apart, that have like the little beads or the powder inside. So different kinds of tablets and capsules. When we're talking about enteric coated, I know we mentioned this a little bit earlier, but just to reinforce, an enteric coated tablet is going to prevent that tablet from dissolving in the stomach acid and makes it not dissolve until it gets to the small intestine. Okay. Super important to note, these medications should never be crushed. If you have an enteral medication and you have a patient who cannot swallow and needs to have crushed medications, you're going to have to call the provider and ask for a different route. Okay, we cannot crush them. They will not work the same. Okay, and then timed release medications. So these are meds that are typically given maybe in a larger dose once or twice a day, but they release slowly over time to produce that effect over the entire day's period or over like a 12 or 14-hour period. And then scored tablets and unscored tablets. So a scored tablet looks like the picture on your screen. So when we're talking about scored, they're just marked in an area that would make it easy to split for us, okay? If it's not scored, it should not be split. It would not be it wouldn't be accurate dosing if we split a tablet that was not scored. So you can see a picture here of the scored tablet. This first one is able to be split directly in half, and the second one is able to be split into quarters. Liquid medications are frequently used for children and older adults. They can also be used in NG tubes or G tubes as well as a different kind of route. They usually come in multi-dose bottles, so you will need to pour individual doses into a disposable calibrated cup. So when pouring liquid medication, super, super important for you to note that the only way to pour medications from a liquid bottle is to hold that bottle so that the liquid doesn't run over the label, making it difficult to read, first of all. And we're always, always, always going to put that medication cup on a flat surface, so a table, as we're pouring. We're never going to hold it in our hand while we're pouring our medication in there because we have to make sure that it's the appropriate dose. So, because of hand movement, you can't really see the dose. Is that appropriately measured if you're holding it in your hand when you're measuring? So always put it on a flat surface, pour the medication into the little cup, and then pour it at eye level so that you can see the medication dose that you're pouring in. Buccal medications and sublingual medications, although they are placed in the mouth, they are actually intended for absorption in those mucous membranes rather than the GI tract. Okay, so some soluble forms of medications and enzyme preparations as well are administered by this route and are super rapidly absorbed, some within seconds. Okay, again, buccal medications are held in the cheek, and the sublingual medications are held underneath the tongue. And then with enteral medications, so these are for patients who cannot swallow or who have feeding tubes. We can give those oral medications through those tubes. Important things to remember is that these tubes are often long and narrow, so they can clog off very quickly. So typically your medications are being crushed and given through these types of tubes. So we want to make sure that they're finely crushed and not super lots of chunky material in there, or it will clog off that tube. Okay. Super important when we are accessing a tube of any kind, you have to make sure that we are checking for tube placement beforehand, okay? And then we always want to flush the tube with water before we put any medication through it. And then medications, when given through a tube, are given one at a time and dissolved in water. So you crush it, dissolve a little bit in water, all in separate containers, and then you give one medication at a time. So pour the medication in, flush it with water, pour the next medication in, flush it with water, etc., so on and so forth. And then another thing with this, so you've checked your placement, you've given your medications, you've flushed with water. You always want to make sure too that before, during, and after this medication administration with the tubes, their head of the bed is at least at 30 degrees to prevent any aspiration. And just some special situations when we're talking about giving oral medication. So there are some medications out there that discolor the teeth. So these types of medications, we want to make sure that we're mixing them with a liquid, and then having the patient drink the solution through a straw instead of just pouring it into their mouth, so that we limit the contact with their teeth. And then after they've drank the liquid, we want to make sure that they drink a liberal amount of juice or water afterwards, to kind of dilute that medication and get it out of the mouth. Okay. Some contraindications to oral medication. So we're not going to give drugs to patients who are NPO unless they're ordered to have. Sometimes you'll have NPO patients who can say NPO with meds. So that's a patient-by-patient basis. So it should always concern you if you see someone who is NPO. That should always be a question that you're asking. Can they have the medications or not? I would never give them medications without direct confirmation that they are able to have them. So that's a huge consideration you want to make sure that you're considering. Patients who are comatose, we are not going to give oral medications to comatose patients. Okay, we're gonna be super careful to patients who are at risk for aspiration or those who can't swallow. Every patient's a little bit different. Orders are a little bit different, but we always want to make sure that we understand that if they're at a large aspiration risk for eating solid food, they're going to be at an aspiration risk for their medication as well. Okay, so we want to make sure that we're considering that. Same with patients who are having nausea or vomiting. Giving them oral medications is probably not going to be the best idea. So if you have a patient who's complaining of nausea, they're probably not going to tolerate their medication. And once you give it to them and they throw up, you have no way of knowing how much of that medication they've absorbed. So giving them an additional dose is almost unheard of. So we want to make sure that, if there's an alternative route that we can ask the provider for, that we do that. That would be a super important thing to follow up on with the nausea and vomiting. And then patients who have difficulty swallowing medications, we can always crush tablets that are able to be crushed. But remember, extended release tablets, things like that, we cannot crush. So, however, if we need to crush them because they have difficulty swallowing, we'll crush them. They'll be able to be mixed with either a liquid that they can drink or a small amount of like applesauce or pudding will help them to be able to take that a lot easier. So topical medications, these are applied directly to a body surface or a cavity. So they do have local and sometimes systemic effects. So remember your difference between local and systemic effects. Sometimes these have both, sometimes they have either or, okay? So lotions, creams, and ointments. So to enhance absorption for these types of meds, if we're gonna give them, we wanna clean the skin with soap and water and pat dry before applying these types of meds. Also, if you warm the medication in your gloved hands, it's going to be more comfortable for the patient, so it's not so cold, and it'll also make the preparation easier to apply, okay? You can use a cotton swab, a tongue blade, or a gloved finger to apply these medications. Making sure that you do have some type of glove PPE on, because remember, you're giving these topically, which means if you are rubbing these in with your bare hand, you're going to absorb them as well. And there's some medications you really don't want that to happen. And then transdermal patches. So these are designed to be absorbed through the skin. Transdermal medications are prepared as patches and made of like a special membrane, okay? The patches allow a constant and controlled amount of medication to be released over a 24-hour period, or sometimes even more. You'll see some patches won't need change for like 3 days. So sometimes it does have a prolonged systemic effect. Some installations that we need to talk about here. So some other routes here. So ophthalmic is going to mean in the eye. Otic is going to mean in the ear. Nasal, through the nose. Vaginal and rectal, self-explanatory, right? So when we're talking about administering medications through the eyes, so ophthalmic ointments and solutions are used typically for their local effects, right? So for example, to treat eye irritation, dry eye, infections, glaucoma, or to lubricate. But there are some medications that are given in an eye drop that can produce systemic effects. So we want to make sure that we know that when we're giving those types of medications, which can be systemic, we want to make sure to put pressure on that lacrimal duct, so the inside corner of the eye, because if those eye drops run through to that inside corner, goes through that duct, it can go to the systemic circulation. So that's an important piece. Always make sure we know when we are administering eye drops that we're pulling down to and then administering the eye drop in the conjunctival sac and not directly onto the pupil or the white of the eye there. Also, having your patient refrain from closing their eyes super tightly right after administration. We want to make sure that they don't do that, because then they can push kind of out those eye drops that we just put in their eyeball. So otic medications. So these are medications given through the ear. So these solutions may be dropped into the ear to treat internal or external ear infections. Could also be a solution to soften and remove earwax as well. So we want to make sure that we are using these solutions at room temperature. That's super important, because a solution that's either too hot or too cold can cause vertigo or dizziness, can cause nausea, and can cause pain. So if a solution has been refrigerated, we want to make sure that we warm it to room temperature by rubbing the bottle between our hands for a minute or two before we use it, okay? Especially if those medications are dispensed in a glass container, because those can get really cold. Remember, anytime you're giving an otic medication, just the same as if you're assessing an ear, you want to make sure that you know to pull the pinna up and back for an adult and down and back for a child. When we're talking about nasal medications, clients are typically self-administering these nasal sprays or nasal drops. The most common nasal medications are going to be used to shrink those swollen mucous membranes and to loosen secretions and provide drainage for treatment of like nasal cavity or sinus infections. Vaginal medications come in various forms, so you may see them as a foam, a jelly, liquids, creams, tablets, and suppositories. They can be used for contraception, to destroy bacteria in the vagina before some kind of gynecological surgery. Can also reduce vaginal dryness related to menopause, treat vaginal itching or infection, and can also be given to induce labor as well. And then rectal medication. So the rectal route may provide for a higher blood level of the medication, actually, because rather than the oral route, because the venous blood from the rectum doesn't pass through the liver before entering the general circulation. So it doesn't go through that first pass effect the way an oral medication does. However, absorption can be affected poorly by stool, depending how much stool is in there. Rectal medication can also be given in a colostomy stoma for certain patients as well. So when we're giving rectal medications, a suppository specifically, we want to make sure that we position our patient in the Sims position. So that's where they're kind of prone with that leg kind of hiked up there. We want to make sure that we're inserting that suppository past the rectal sphincter and along the rectal wall. Okay, it cannot absorb if it's not along the wall. So don't just throw it in there right in the middle of their bowel. You want to kind of push it up against the rectal wall. And then it's important to educate your patient to remain sidelined for at least 10 minutes after administration. And if they have the urge to defecate, to try to hold it the best that they can. We don't want them to release the suppository or it's not going to work. So respiratory inhalations is another route of med-admin that we're going to need to know. So anything that's going to be given respiratory is going to use the concept of nebulization. So this is the production of a fine spray or like a fog, or like a powder that's going to, we're going to inhale that powder, or like a mist that is made from a liquid drug. So in these, a patient's going to inhale that medication mixture by taking a big deep breath through a mouthpiece on an inhaler, as you can see in the picture. That is attached to some kind of nebulizer system. So there's a system like that in an inhaler. You've also, if you've ever seen like an actual nebulizer where the liquid medication kind of goes in the little cup holder and then the patient can breathe it in via like a mask or like a mouthpiece. What ends up happening is they're going to inhale that medication, that mist, that powder, that spray, and it's going to go down through all the branches of the lungs into the alveoli, those tiny air sacs in the lungs, and then that's where it's going to absorb across that capillary membrane and get into the blood supply for absorption. So a couple examples of respiratory inhalations that we're going to see. So we talked a little bit about a nebulizer. So if you've ever seen one of those, this is where it's like hooked up to like a machine via like a oxygen type tubing looking cord, and then there's like a little reservoir that we can put a small volume of medication in there. Usually it's going to be like albuterol or some kind of mixture of something that's going to help dilate those bronchioles and cause the patient to be able to breathe better. So typically we're given like a milliliter, maybe 3 milliliters. It can be normal saline, it can be medication, and we're going to put that in that reservoir, screw the top back on, and then the part that the medication comes out of is either a mouthpiece that they can just put right in their mouth, or it can come through a mask and then they can inhale it with their nose or with their mouth, and that fine mist is absorbed like deep into the lungs. Another example is an inhaler, as everybody's probably seen before. We call it a metered dose inhaler or an MDI. So what this is, it's a pressurized container that's pre-filled with several doses of a drug. Again, it could be albuterol, anything that's going to kind of dilate those bronchioles and ease the work of breathing. So typically with that, as you can see with this lady in the picture, what's going to happen is that patient is going to exhale all of their air just in the same way that we tell them to do before they do that incentive spirometer. They're going to exhale all of that air. They're going to time their inhale with the time that they release that canister pump there. So they're going to give themselves a pump of medication, take a deep inhale, and that's going to release that medication and get it into their lungs through that mouthpiece. Now, in order to receive an appropriate dose of medication through an MDI, we have to make sure that our patient can coordinate that timing of releasing that medication through that canister and then also timing that inhale as well, right? So if we have a patient who's not very coordinated, they may pump that and then wait a few seconds to breathe, or they may not even have really the strength to pump it. Or I'm talking mostly children is really where this becomes an issue, or the elderly, where they can't get that coordination to where they pump and then inhale very quickly. So they don't get that most effective dose of medication. So in these types of instances, you may see a spacer being used on an MDI. So it's kind of an extender piece to an inhaler, and it's attached to that mouthpiece of the inhaler. And what it does is it's going to enhance the delivery of the medication into that respiratory tract. Okay, so what's going to happen? I'll show you a picture here on the next slide, but the medication is going to be pumped into that extender or that long reservoir instead of directly into the patient's mouth. So that drug's going to be suspended in that reservoir. The patient's going to be able to inhale the drug from that chamber whenever they're ready. So it kind of takes that time pressure off. So right here you can see a picture of a metered dose inhaler with a spacer attached there at the very bottom. So at the bottom you can see there's the inhaler off to the left with the orange little covering on it. That silver piece at the top above the orange is what the patient's going to press onto to get the medication to come out. And then the medication, once they push that, is going to come out and it's going to be suspended into this chamber here. You can see this long tube here. And that what's going to happen is going to keep it suspended into the air so that if your patient has like poor coordination, they can't time their breathing and all of that very well, we can put their mouth on the mouthpiece at the end. It will be suspended there, ready for them to take a breath if they don't like coordinate it very well. So this is especially helpful, again, for children and for the elderly. So big things when we're talking about metered dose inhalers, whether they're given with or without a spacer, it doesn't matter. We want to make sure that they rinse their mouth before we do the inhaler so that we can keep the mouthpiece with the least amount of bacteria on it as possible. Always shake the metered dose inhaler before we give it so that we can make sure that the contents are all mixed up and that they're getting an equal amount of medication. Again, we want them to totally clear their lungs, so breathe out slowly, breathe all of their air out, and then breathe slowly in as they puff that inhaler. Hold their breath for 10 seconds, and then they can breathe out as well. Again, there's many different kind of medications that can be given through an inhaler, but specifically a good point to remember is that if you are giving your patient a corticosteroid inhaler, we have to make sure that they rinse their mouth after they use it, okay? Because that can cause lots of infections and things like that. Can cause like white patches in their mouth. We want to make sure that they're rinsing their mouth after they use a corticosteroid inhaler. We also want to make sure we're wiping clean that mouthpiece. And just a pro tip, do not soak the whole device to clean this inhaler because it can damage the valve mechanism in it. So just wiping clean that mouthpiece is about as good as we're going to get. So we're going to learn about parenteral medications. So we've learned a couple words through this PowerPoint, right? So we are talking about, earlier we were talking about enteral medications. So anything that bypasses the mouth. And then now we're talking about parenteral medications. And this just means anything that you are injecting or infusing into a patient. Okay, so usually it's going either into the veins, into the subcutaneous tissue. Any type of injection that you're giving is encompassed under parenteral medications. So we're going to learn all these different routes of parenteral medication administration. So first, we're going to talk about intradermal medications. This is going to be directly below the skin, and we've got slides for each of these, so we'll go in depth into all of them. But these are the 4 routes that you can give medications parenterally that you need to know. So intradermal, again, that's right into the dermis, right underneath that first layer of skin. Subcutaneous, that's in the fatty tissue. Intramuscular is going to be given into a muscle, and intravenous is going to be into the vein. The big thing you want to remember with any of these medications is that we don't choose the site that we're giving it or I guess we don't choose the route, right? So we don't choose whether a medication is given subcutaneously or intramuscularly. These are going to be in the manufacturer's directions, and they're going to be in our provider's orders, or our provider is going to tell us how we're going to administer this. That being said, the reason that it's administered a certain way is because of how it's best absorbed. So if you're giving a medication in the subcutaneous tissue, it's because that's the best way that this can be absorbed and tolerated by the body. Same goes with any other route. However, when they give us a route, they could say, we need this administered subcutaneously, and we get to choose the site with our patient because there's multiple subcutaneous sites we could choose from, and that is our choice. So they give us the route, we choose the site. Couple of things I want to talk about a little bit when we're talking about intravenous medications. Again, these are given through the vein. With this, the onset of medication action is going to take place within seconds because there's no real absorption time, right? Because that absorption is about the med getting into the bloodstream. We're putting it directly there. So absorption, super, super fast, almost immediately. Okay. That is especially useful to have IV access in an emergency, right? Because we want our medications to work super, super fast. However, because an IV drug begins to act so quickly, almost immediately, there is no way for you to stop that action if an adverse reaction occurs, unless there is some kind of known antidote. So it's a good thing, but it also can be a bad thing as well. When we are giving parenteral medication, we need some certain supplies. So we are going to need a syringe. So the syringe, remember, is just the part that holds the medication. It has the plunger inside. When we do all of our syringe reading quizzes, that shows the lines and how much med we're drawing up. That is just the syringe part. Typically, that is packaged alone. There's not a needle usually attached to that because depending on what kind of injection we're giving, we choose the size of the needle based on what is going to work best, right? So that's the other thing we need is the needle to put on the syringe, okay? So depending on the route that we are giving that medication, the needle length and the needle gauge is going to change, okay? Because think about it about basic anatomy. If we are giving a medication into the muscle and we want this medication to go to the muscle, we're going to need a longer needle than if we were trying to give it into the fatty tissue from a subcutaneous route, okay? So if we give an IM injection, intramuscular injection with a shorter needle, we're going to give the whole needle to the patient and it's probably not going to reach the muscle. Therefore, it's not going to absorb appropriately or the way that we want it to. Okay. So choosing the needle size and gauge is super, super important for us to know the difference and what sizes we need to have for each one. And we will talk about that in the slides oncoming. There's a table in your book that you can review. However, for most of these slides, I got the information from that table, and we will practice all of this hands-on in the lab as well. The other thing we're going to need is either a vial or an ampule, whatever it is that we're drawing this medication up from, we're going to need. So I have a picture on this slide of a vial. It's got the blue top with the red medication in it. So you can have a single dose vial, which has one dose of medication. So if there's anything left, you toss it, or you're supposed to give it all if they have all of it ordered, right? So that can be a single dose vial or a multi-dose vial. And they may have a vial of, let's say, long-acting insulin where it has, maybe it's packaged with, 1,000 units of insulin in the whole bottle, but they're only going to pull out the insulin that they need each time. So a multi-dose vial. Vials have a rubber stopper that's going to reseal the top after each needle introduction. Okay, typically a plastic or a metal cap covers the rubber stopper to protect it until it's used. You can see the blue cap in the picture over here. Because the vial, and we'll practice this in lab, but just keep in mind, because this vial is a closed system, so there's no air coming in or out, just you poking, and then after you take that needle out, it reseals, right? So it's a closed system. So because of that, we do have to consider the pressure difference because if you were to just insert your needle in there and start to try to draw medication back, it's going to be really hard for you to do that because of the pressure in the vial. So because of that, we are actually drawing up air in our syringe and then putting the air in the vial and then drawing out our medication. It equalizes the pressure and allows us to pull back the med a lot easier. So what's going to end up happening is if you don't do that step with the air, a vacuum is created in that vial and it makes it super difficult to withdraw that medication. So that's a vial. Another thing that you may see and that you will see in lab as we practice is an ampule. So you can see a picture here of multiple ampules there, brown ones, white ones. And they're kind of tall and funny looking. You can see that there's a bottom piece of it and then there's almost like a line right there. And then there's a top like little cone head looking piece. Okay. What these are like a thin walled disposable glass container with this narrow neck here. That narrow neck and that line right there is made so that we can break that glass and then access the medication. A lot of times medications are stored in ampules because it has something to do with like their shelf life, or sometimes they're not good for being exposed to light. Like some of these are brown in color. So it just has to do with like medication storage and safety, which is why they're packaged like this. Only some medications come in this way. However, we do always, every time we have to give a med via an ampule, we do have to break that neck. Okay. When we break that neck, we have to take care of a couple things. So first of all, when we're breaking that, there's going to be glass shards, okay? And you're going to create a sharp piece of glass. So you want to protect yourself. So always use a piece of gauze or an alcohol pad to break that neck of the ampule. So the other thing we want to be careful of is that glass fragments are going to probably, or at least possibly, fall back into the glass container and mix with the medication, okay? So since there may be glass fragments in there, anytime you're drawing up medication from a broken ampule, you need to use what's called a filter needle. And I'll show you what that looks like on the next slide, and we'll practice that in lab as well. But anytime you're drawing up from an ampule, you have to use a filter needle. A couple other important things that you'll see when we start to do medication preparation is you're going to see reconstituting meds from a powder. So medications that are not stable in a solution are dispensed in powder as powder inside vials. So you'll see a vial and it'll just be full of powder, okay? What we are going to have to do with that is before we give it, we're going to have to dilute the med with whatever the manufacturer's instructions or the provider's order tells us to do. So we may have a vial full of powder and it may say dilute with 10 milliliters of normal saline, in which case we would just put 10 milliliters of normal saline in there, mix it all up, and then we'd be able to draw out the appropriate dose. Keep in mind when we're talking about reconstituting, and we will hit this in math and do some math problems that require this skill in a week or two. But just keep in mind the same concept that we kind of discussed a little bit with electrolytes as far as dilution and concentration apply here. So the more fluid or the more diluent that you're adding to this powder, the less concentrated the medication is going to be. The less liquid that you're adding to the medication, the more concentrated it's going to be. Okay, so you'll end up having more units or more milligrams per milliliter if you add less fluid than if you were to add a lot of fluid, you would have less units or milligrams per milliliter. So again, we don't get to choose. We just need to know that that concept exists as we are reconstituting medications. And then another thing you may see, and that we will practice in lab as well, is mixing two medications into one syringe. So you can mix two medications in the same syringe, one, if they're compatible, and two, if the total dose is within accepted limits, and obviously number three, if they are both to be given by the same route. A perk of this is that this technique allows for efficient use of supplies and also allows the patient to get fewer injections, which they appreciate. Okay. Just keep in mind, medications are compatible if they can be mixed without affecting their constituting or their actions, their constituents or their actions. Typically, you'll find this information in a package insert. What we will practice in lab is mixing two different kinds of insulins to cover our patient who is receiving insulin and giving that subcutaneously. So here on this slide, you can see, I have that picture of ampules again. This second picture here you can see is of a nurse prepping this ampule, so about to break it off so that we can expose that medication and draw it up. And then all the way off to the right, you can see two examples of a filter needle. So what a filter needle is first of all, it is a huge needle, okay? It is a huge hollow needle with a filter inside. Okay, so the only purpose of a filter needle is so that we can draw up this medication from the ampule, and then that way that filter will collect all the glass before it goes into the syringe. So the filter filters out that glass, allows the medication to go directly into the syringe, which is where we want it. We use the filter needle for that. And then as soon as we draw that up, we take the filter needle off and put it in the sharps and then replace it with a needle of the size that we need. We never, ever, ever give an injection with a filter needle. Okay, it is always taken off and replaced and only used to draw up medication. That's super important to know. And we'll practice this part in lab as well. So, about intradermal injections, medications given into the dermis are going to be given intradermally, okay, into the dermis, okay, into the layer of skin that's located directly beneath the skin surface, okay. The intradermal route is commonly used for allergy testing or tuberculosis testing, okay. Most nurses use the patient's non-dominant forearm for TB screening for these injections. You can also use the chest, the upper back, and the forearms can be used for the intradermal injection. So everything on these slides about these routes you need to know, okay? So sites for an intradermal injection, forearm, chest, upper back. Max volume of medication. This site cannot handle a large amount of medication. So 0.1 milliliters is the max amount of medication that is given intradermally. Your needle gauge is going to be a 26 to a 28 gauge needle. And then your needle length is a 3/8 of an inch to 3/4 of an inch needle length. So pretty short, tiny. And then when we're doing our injection, we're going to go in at an angle of 5 to 15 degrees. So this one is almost parallel with the forearm when we give it. That's kind of the style that we need to do. One big thing when we're giving intradermal injections or after we've given one, specifically these ones where you need to make a wheal or a bleb or whatever you want to call it. It can be interchanged. And so that's going to be that little bump of medication right underneath the skin surface that you've seen in your tuberculosis testing, right? So when we are doing that type of testing and we are inserting that medication, it's going to make a bleb or a wheal. That's what we want to be there, okay? So after that injection, we want to make sure that we apply absolutely no pressure to that area after injection, because if you start to push down or like push the blood, so you're applying pressure because it's bleeding a little bit, the body, the rest of the layers of the skin are going to absorb that medication, and we don't want it to absorb it because we want the body to have or potentially have a localized reaction to that medication, okay? That's why it's used for allergy testing or tuberculosis, because we're looking for a skin reaction, right? So if the body absorbs the medication, we're not going to see a skin reaction. So apply no pressure. If you have to get rid of blood, we want to just very gently dab the blood away from the site. So this slide is just showing you a photo of where your intradermal injection sites are located. Anything there in the red is an appropriate site to give our injection. When we're talking about subcutaneous injections, so these types of medications are going to be given into the subcutaneous tissue, which is the layer of fat located right below the dermis and right above the muscle tissue. Absorption is slower than it is through the intramuscular route, so subcutaneous meds absorb slower than IM meds because the subcutaneous tissue does not have as rich of a blood supply as muscle tissue. Okay. However, the speed of absorption with subcutaneous injections varies based on the site that you select. So sites in the abdomen and the arms are typically going to be the fastest absorbing. Whereas those on the thigh and the upper buttocks are the slowest absorbing, okay? Medication is absorbed more evenly from the abdomen than from the thighs and buttocks because it is less affected by activity of the patient, okay? So for subcutaneous injection sites, we're looking at the fatty part of the abdomen, the fatty part of the back of the arms, the lower back, upper buttocks. Okay, max amount of medication in a syringe is 1 milliliter. We don't want to put any more than 1 milliliter in a subcutaneous syringe and give it to a patient. Needle gauge is 25 to 27, and then your needle length is 3/8 of an inch to 5/8 of an inch. So again, pretty short. And then your angle of injection is going to be from 45 to 90 degrees. So the angle in which you inject, whether it's 45 degree or 90 degree, is going to depend kind of on the weight of the patient, okay? Because if we have a super, super thin patient and we go in at a 90 degree angle with our injection, we are going to probably go past the subcutaneous tissue and closer to the muscle if the patient's super, super thin. Whereas if the patient is super heavy and we go in at a 45-degree angle, again, we may not hit the subcutaneous tissue that we want to do. So it depends on the weight of the patient. So if you have a thin patient, you're going to inject at a 45-degree angle so that we make sure we get it into that subcutaneous tissue. Whereas if you have a heavier patient, we're going to go in at a 90-degree angle so that we can make sure that we get in deep enough to that subcutaneous tissue for it to work. And all of that depends on how much skin that we can pinch at the site. And we'll talk more about this in lab as we practice the skills. And then here's a graphic just showing you all of the subcutaneous injection sites that we have to choose from. So when we're talking about giving an intramuscular injection, so this is going to be any injection into muscle tissue. So medications are absorbed faster than subcutaneous medications because of the rich blood supply that there is in the muscle. So it is absorbed a little faster. Muscles can tolerate more fluid typically than subcutaneous injections. You can give as much as 5 milliliters of medication into the vastus lateralis muscle, that thick thigh muscle in the leg, because it's a huge muscle and it can tolerate that amount of fluid. The smaller the muscle, the less fluid that it can tolerate. So it does kind of depend on the max volume, depends on what muscle you're choosing to do. So when we're talking about this, there are 3 sites that are approved to give for, or recommended, I should say, for intramuscular injection. So those include the deltoid, the vastus lateralis, and the ventrogluteal. Okay, we'll go through all of those. They did used to recommend the rectus femoris site and the dorsogluteal site, but neither one are recommended anymore because of their close proximity to the sciatic nerve and the high risk for nerve damage when giving those injections. So these are the 3 we want to stick to. So first, we'll talk about the deltoid muscle. So this is that muscle there in the arm or the shoulder area. I'm sure that you've had a flu shot there before, some kind of vaccine injection of some kind. And so typically this one is very easy to use because it's easily accessible. So this is most of the time where healthcare providers are going to go. The thing is, it's a relatively small muscle, so it's only going to tolerate 0.5 to a whole milliliter of fluid. So maximum 1 milliliter of fluid. So if you have a lot more than a milliliter to give someone, you're not going to be able to give it in the deltoid. Needle gauge 22 to 25, which is the same for all 3 of these sites. And then needle length for this is 1 to 3 inches. For most normal average sized adults, 1.5 inches for a needle is gonna work just fine. However, if you have like an obese patient with a lot of adipose tissue there, you may need to go up to as much as a 3-inch long needle. And then with all of these injection sites, all of these intramuscular sites, we're looking at a 90-degree insertion angle. Okay, this goes for all of them. The only exception is when we are giving an injection intramuscularly to an infant in the vastus lateralis, we're going to go at a 45-degree angle for that. So moving on to the vastus lateralis. So that is that big, thick thigh muscle. They're in like the outer third of the thigh on both legs. It's a huge muscle, so it can tolerate a lot of fluid, okay? So max volume for infants and kids younger than 12 and younger, we're looking at a max volume of 2 milliliters. So 1 to 2 mils we can give their max volume is 2. For adults, though, they can handle as much as 5 milliliters of fluid in that big old muscle. Again, needle gauge 22 to 25. Needle length, we're looking at 1 inch to 1.25 inches for infants and kids 12 and younger because they're going to need a smaller needle length because their bodies are smaller, right? And then for adults, we're looking at 1.5 inches to 3-inch long needle. And then again, all adults are getting a 90-degree injection angle for all IM injections. And then again, just to reiterate, anytime we are giving an IM injection to an infant, we are picking the vastus lateralis muscle. That is the only spot that we're going for these young babies, okay? And then when we give that medication, we're going to go in at a 45-degree angle instead of a 90-degree angle for them, okay? And then lastly is going to be the ventrogluteal muscle. So for this one's kind of on like the side of the hip, kind of, yeah, like the side of the hip, not really making it to the buttocks yet. And again, I'll show you some pictures here shortly. And then we will also practice locating these IM injection sites in lab as well. But for this one, this is probably the most awkward to find. However, it is an approved site and generally well tolerated by patients. Max volume 3 milliliters. So we're given 2.5 to 3 milliliters to these patients. Needle gauge, again, 22 to 25. Needle length, 1.5 to 3 inches for this one. And then again, all the way, always with the IM injections at 90 degrees. Here is a picture of that deltoid muscle and someone finding that injection site, which is a whole method to do that, which we'll actually talk about in practice in lab. Here is that ventrogluteal injection site. So yeah, kind of off to the side, right there on the hip there. And this is someone using their landmarks to try to find that injection site, which again, we will practice in lab when we get there. And then this is your vastus lateralis injection site on an adult. So you can see it's the outer third of that thigh. And it's just like big, bulky. You could probably find it on yourself. It's a big, big muscle in the leg. And here is finding that same vastus lateralis injection site, but this time on a child. Another big thing that comes along with doing any type of parenteral medication administration involves sharps safety. So we have to, first of all, know how to prevent needle stick injuries, because that is going to be one thing that can spread communicable disease, bloodborne pathogens to you if you're not careful from your patient. Who knows what your patient has? So we want to prevent needle stick injuries best that we possibly can. To us, to our patients, to visitors and family, to the people who dispose of the trash and the sharps containers at the hospital or the facility that we're working at. We want to keep everyone safe. So because all needles, I shouldn't say all, most needles these days are coming with a safety feature. So as soon as you're done using the needle for the injection, apply that safety. Do not move a step or a muscle before that safety is applied, okay? If your syringe and needle do not come with a safety feature, and that will happen most likely, I do see some still out there circulating, okay? If it doesn't have a safety, you have to do your one-handed scoop technique, okay? And I'll demonstrate this in lab. But essentially, the point is that you're not using both hands. You're not putting your needle cap in one hand and your syringe in the other and then capping it, because you run the risk of needle sticking yourself if you do that. So rather, we set the cap on the table and then we kind of use one hand to scoop it into the cap. And then once the cap is covering the needle, we kind of push to keep that cap on there. And that prevents the needle from being exposed and coming into close contact with our fingers and getting stuck that way. However, if your needle does come with a safety, there is absolutely no reason to recap it. So do not ever recap a needle unless it is absolutely necessary, okay? But also, don't ever walk to a sharps container or anything with an uncapped needle. So it either needs to be capped if there's no safety feature, or the safety feature needs to be engaged, okay? All used needles and syringes go directly into a sharps container, a puncture-proof sharps container, as you can see on this slide. Do not ever stick used needles or syringes into the mattress. That is the thing that has been done before. Do not ever do that. Try to prevent leaving needles and syringes at the side of the bed or on the bedside table or in the bed, okay? And also, never, ever, ever are we throwing needles and syringes in the regular trash can. Always, always, always in a puncture-proof container, sharps container. And then lastly, when we have patients who are self-administering their medications, or they're leaving with a new prescription, or they're getting discharged and we're providing that discharge teaching, we need to make sure that we teach our patients appropriately, because otherwise they go home, they mishear things, they're not familiar, they assume the wrong things, and they end up being non-compliant and readmitted. So we're going to teach our patient, hey, you need to know and understand what you're taking in order to make sure that your drugs are being used safely and effectively. So we're going to let them know when you're prescribed a new medication, ask why you're taking it, how long you should take it, what side effects should you expect, whether you should take it with food, know about any special precautions, okay? And we also want to educate them to keep a list of their medications, including the dose that they take and the times that they take it, and then take that list with them when they visit any health care provider or emergency department or whatever it is. Next, we're going to make sure that they take their drug as prescribed. So we're going to make sure that they take it for the entire length of time that it's prescribed. So if it's an antibiotic, you're taking your entire dose. You're not stopping just because you feel better, right? We want to make sure that we are aware that older adults may forget to take their medication. So we want to make sure to recommend things that may work for them, like telling them to make out a written schedule or have like a pill container that has the days of the week on it, or a medication calendar, or things like that. We want to also be aware that a lot of elderly patients have vision problems. So if they can't see well, let's see if we can ask a family member to write out our schedule, or if we can get something with larger print or something to facilitate them to be able to acknowledge and read and remember and all of those kinds of things. We want to encourage the patient to communicate with their prescriber. So notify your prescriber if you have any of the side effects, adverse reactions, or any questions, okay? We also want to make sure to educate, hey, if you become pregnant, you need to make sure that, these medications are safe. So notify your doctor as soon as possible and let them know. So if any of these meds need discontinued or adjusted, they can do so. We also want to make sure that they are educated about safety. So teaching them, be aware of your safety and the safety of others. So first of all, wear your medical alert bracelet or necklace if you're diabetic, or if you are taking anticoagulants, or if you have any allergies to any medication, so that any emergency personnel would know these things. Do not take medications prescribed to other people, and do not share your medications with others. If you take a variety of medications, post a list of them in a prominent place so that it can be easily taken. If you are doing med education on patients who have young children at home, make sure that they know to use child-proof caps, and make sure that, make sure that those medications are out of the reach of children. Make sure that they know to dispose of any expired medications safely, not by throwing them in the trash and not by putting them in the sink or the toilet, because that's just going to be right back in our water supply. Okay? Make sure that they're administering their own drugs correctly. So encourage them to read the label carefully on the bottle each time they take the medication, so that they know they're taking the right dose. Let them know, hey, many tablets look alike, right? Make sure that when they're measuring liquids, you're using, make sure that they're using the appropriate tools to measure their liquid medication. Because if they're using kitchen tools or like an actual teaspoon instead of a measuring cup, it's not going to be as accurate. We need to be especially diligent in doing exceptional teaching for patients who are required to do parenteral med administration at home. So for example, insulin. Too much insulin can kill someone. We can kill people with it, and they can kill themselves with it. So we want to make sure that we are teaching them, first of all, what does this do in the body? How much of this should I be taking? How do I read this syringe? What happens if I take too much? What happens if I don't take enough, right? So we need to provide all that education. We also want to make sure that patients know, and that you know as the nurse, that anytime you have a patient who's taking routine injections, we want to make sure that they know, hey, you need to rotate these injection sites, okay? Because scar tissue can build up, absorption will decrease because of that over time. We also want to make sure that they know to store their drugs safely. Don't store a drug in a different container from the one that it came in, because at that point the medication may lose its strength, or you may take the wrong medication thinking it's something different. Store them all in a nice dry place, out of sunlight and away from heat. And if a medication requires cold storage, be sure that you return it to the refrigerator as soon as you're done using it. And lastly, make sure that they're maintaining their med supply. So your drugs need to be up to date and available when you need them, right? So monitor your prescription amounts, get refills before you run out. If your medications come by mail, make sure that you order them in plenty of time. Make sure they're checking expiration dates and properly discarding any expired medications. And then educating them to not take their expired medications because they may have lost their strength at that point.